Good evening, ladies and gentlemen. I would request everyone to settle down so that we can begin the session. I would request everyone to settle down so that we Good evening, ladies and gentlemen. I'm Dr. Chakravyuh from the Department of Clinical Hematology, Amrita Hospital, Kochi. On behalf of the organizing committee, it's my privilege to welcome you all to day 1 of Chakravyuh 2.0, a two-day symposium dedicated to the advancement of hemophilia care in India and beyond. The word Chakravyuh, borrowed from Indian mythology, symbolizes a complex formation, one that demands intellect, teamwork, and resilience to navigate. In the context of hemophilia, it represents the multifaceted challenges faced by patients, caregivers, and healthcare providers. Chakravyuh 2.0 is a collaborative effort by the National Health Mission Kerala, Amrita Hospital Kochi, in association with the World Federation of Hemophilia, Federation of Hemophilia India, Hemophilia Society Cochin Chapter. The success of Ashadhara program, a nationally acclaimed public-private initiative in Kerala, highlights what is possible when policy, science, and compassion come together. Following the success of Chakravyuh's first edition in 2020, we now gather again, more experienced, more connected, and more determined to shape the future of hemophilia care in India. I would now like to invite Dr. Neeraj Siddharthan on the stage for his welcome address.
Health Mission Kerala and Amrita Hospital Kochi. For those of you who remember, the first edition of Chakravyuh was held in 2020 during COVID, and it was a virtual one, and most of our faculty here are present virtually in that. We were fortunate to have them there. And so it is truly heartening to see how far we have come since then. This symposium represents more than just an academic gathering. It's a platform, like you can see in the picture behind me, that brings together doctors, healthcare professionals, policymakers, members of media, patient support groups, and most importantly, patients and their families who remain at the very center of everything that we do. So the name Chakravyuh has been drawn from the great Indian epic Mahabharata. Here it stands for a protective circle of care that we strive to build around every patient with hemophilia and bleeding disorders. A system that is robust, inclusive, and unbreakable, hopefully. So the remarkable transformation in care that we are witnessing today in the care of hemophilic patients over the last few years, including clinicians, scientists, government agencies, advocacy groups, and industry partners. And this change has not happened overnight. And today, we take a moment to recognize and thank every single person who has contributed in this journey. All of you have come from far. Jan has traveled almost, I think, 10,000 kilometers or more and come here. Alok sir and some of you had a very unforgettable experience in the flight. So all of you have taken a lot of pains and come here, and I sincerely thank each of you for with us today, starting with Professor Alok Srivastava, Global Authority in Hemophilia and Principal Author of WFH Guidelines, Dr. Jan Blatny, a former Health Minister of Czech Republic and internationally respected voice in rare bleeding disorders and hemophilia, Mr. Prem Alva, whose tireless as a HFI President, whose tireless efforts have strengthened the patient advocacy, and Mr. Harshal Kale, from World Federation of Hemophilia, whose support and vision have brought us all together here. So I extend a warm welcome to all our faculty, delegates, industry partners, and every member of the organizing team who made this event possible. I'm sorry, my apologies for the shortcomings that you have faced, and we will definitely try to improve upon. Improving our hospitality. A heartfelt thanks also to Team Marriott for hosting this evening. Let us use these 2 days for not only to share knowledge but also to renew our commitment to every individual living with a bleeding disorder in Kerala and beyond. So thank you and welcome once again to Chakravyuh 2.0, and I would invite my co-host Dr. Rahul Yuva to speak a few words. Thank you, sir. Good evening, everybody. So today, this evening is a very special evening for us because it's 5 years now since we conducted Chakravyuh 1. So from the initial discussions, online discussions at the time of COVID, to initiate a state-specific program. From there, now we stand with an Ashadara program which we can proudly present before the entire country or even abroad. So I'm very lucky to have a team of many experts, technical experts, treating doctors, district level teams, the patient advocacy groups, and each and every family and family members of the hemophilia family. So together we have moved forward this much. So when I had a discussion with Dr. Neeraj regarding conducting a state update for Kerala, we didn't have a second thought on choosing a name for the program because we wanted to have the Chakravyuh 2.0 to see where we have reached, where we should head, and to have a proper plan after this 2-day seminar on our way forward. So that's why we have selected 5 key areas for discussion, one of which is obviously the theme for this year, it is Women and Girls Bleed Too. So we have developed a state-specific guideline for women with bleeding issues, which will be presented tomorrow for your all opinions and further clarifications before the final release of the document and training of healthcare professionals. Apart from that, we are focusing on the principles of care and where the treatment scenario is leading to, and also how we are assessing setting we can move that. So all these sessions are planned to be the steps on which we have to build the next 5 or 10 years of care. So once again, I would like to welcome each and everyone, and I wish you all to be actively participating in these discussions and your contributions, because each and every one of you, your experience and expertise in hemophilia care is valued. It is very important for shaping the future. Thank you very much once again. That is a very interactive and very good sessions and experience. Thank you very much.
Thank you, Dr. Neeraj and Dr. Rahul, for addressing the session. It is with great honor to welcome you all to the first session of the day, which is on revolution in hemophilia. I would like to invite our esteemed chairpersons for this session, Dr. Neeraj Siddharthan, Professor and Head, Department of Clinical Hematology and Stem Cell Transplant. Dr. Geeta, Professor of Hematology and Medicine at GMC Hospital, Capital. For our first session, I would like to invite a distinguished speaker to the stage, Dr. Jan Blankney. Dr. Blankney is a consultant hematologist and associate professor of pediatrics at Maastricht University and University Children's Hospital Brno in the Czech Republic. He is a globally respected authority in pediatric hematology and bleeding disorders. He also held a portfolio for Minister of Health of Czech Republic. Over the years, Dr. Blankney held key leadership roles in the European Hematology Association, World Federation of Hemophilia, and Czech National Health Authorities. His contributions have been instrumental in shaping evidence-based guidelines, advancing early diagnosis, and establishing comprehensive care models across Europe and the world. His visionary work continues to bridge the gap between pediatric and adult care, ensuring better outcomes for patients at every stage of life. Please join me with a huge round of applause for welcoming Dr. Jan Blankney on the stage as he shares his insights on the revolution in hemophilia. Over to the chairperson to welcome him.
Thank you, Shreya, for the very nice introduction to Dr. Jan Blankney. If I may add to that, Dr. Jan is, transformed the hemophilia care in the country he comes from, that is the Czech Republic. From the data that I have been fortunate to be, an observer at his hospital for about 2 weeks. Long back in 2018, I think, and it was truly a very enriching experience, which maybe I think shaped my outlook on what things can be done and how hurdles can be overcome. And it was truly inspirational, and I think you would know from his talk now and how inspirational and nice he is as a speaker. Jan, thank you very much for accepting our invitation and being here today.
Let me thank you very much for the possibility to be here today with you. It is my greatest and utmost honor, pleasure pleasure to be here, and I'd like to thank you once again to Dr. Milic, to Professor Allen, to all of you for the possibility to share some thoughts with you today. Though I'm coming from the country which had some experience with revolutions, I'm not the big fan of revolutions. I rather prefer evolution. But currently I think we are witnessing revolutionary changes in the hemophilia care, and this is what I would like to discuss with you today. This is the actual conflicts of interest, the entirely transplant, but this talk is not supported by anybody. And I would like to start with a bit of history of hemophilia and the treatment in past and now, future treatment, and to make it a bit more interesting for you, I would like to add also some real-world data which were generated with the help of two of my PhD students. And perhaps because I do not see on the slides if I'm looking like this, may I get the microphone to my hand? That would be more convenient if it's possible. Thank you very much. It's almost working.
It's not working.
Totally perfect. Good. So, to start about the history of hemophilia, we should go really back to the old times. And the fact that people realized many hundreds and thousands of years ago that hemophilia is a severe disease and it is a very difficult disease, we can find the witnessing of this, for example, in the Jewish Talmud, where you find the information that if there is a child whose two older brothers died because of the bleeding during circumcision, this particular child shall not be circumcised. So this is the information given to us that they already knew that it is inherited and that it is really severe. Then it was considered to be some sort of curse, let's say, and you know, I'm sure you know the lady on the picture, this is Queen Victoria, and she spread the hemophilia B gene to many other royal families around the globe, and the last living member of this family was young Russian Prince Alexei, who died in the beginning of last century. But hemophilia was not considered to be only the chromosome, something which is mystic, but it got to the center of the science. It became a challenge. And as we all know, in the 1828, a young student of Professor Schönlein in Zurich, whose name was Friedrich Hopf, used the name Hemophilia. And it's a bit changed since that, but since these years, the word hemophilia started to be used for this bleeding disorder. And later on, the congenital factor A deficiency was proven to be cause of hemophilia A, and later on also we realized what is behind hemophilia B. And what really made the change was the start of industrial production of factor concentrates, and it was in 65. On this picture, which is from the newspaper at that time, we can see how difficult, and many of us do remember it even from our patients, how difficult it was to treat the patients in the past. Because, for example, this boy needed 190 pints of blood per year, and the students were collecting this blood for 10 years for him, and that was something which was remarkable at these times. But this is all the past. And what is the future? when we think about the future, we should always realize how difficult the original treatment was. This man on the right is Russian monk Rasputin, who was somehow treating young prince 100 years ago. But obviously this treatment was not sufficient and was not working properly. If we have a time, somewhere during the sessions, we can discuss how this man probably helped young prince, because it is quite an interesting story, but we don't have a time to discuss it now. The treatment based on scientific evidence started when we realized that plasma is correcting the bleeding time in hemophiliacs, and transfusion of whole blood before the World War II, and then discovery of cryoprecipitate later on in the 60s moved the thing forward. When I was trying to find somebody, a picture of a boy with typical hemophilia arthropathy like you see on the screen, I had to really dig into our archives quite deeply. This picture you see on the slide is from 70s of last century. This is the time when I was born. Should I be wanting to find such a picture now in my country, I would not be able. And this is something which is sooner or later happening all around the globe, because the treatment is improving so dramatically that these pictures sooner or later will not be available anywhere in the world. And that is the goal we should all focus on. So what were the modern milestones in the treatment of hemophilia? Indeed, me coming from Europe will be looking on it from the European perspective, but anyway, 65 plasma factor concentrates used for the first time, and 1980 there was a big tragedy because of the HIV spread around the globe, mostly in the US and Western Europe, but anyway, it was a hit of the whole hemophilia population around the globe. Do you know what this picture is? What is it showing? This is the Iron Curtain. This is how the border between Eastern and Western Europe looked like. This particular picture I took in the Museum of the Iron Curtain, so it's not there anymore. But there was one and only one good thing what the Iron Curtain did for us. And that was because we were not able to travel, and we were not able to bring anything from the West. We did not have any HIV. We had only 32 patients with HIV in at that time 16 million country. But nevertheless, I would never advocate for any iron cartridge anywhere. 1985, genes for factor 8 and factor 9 were cloned, and then the first clinical use of recombinant factor 8 concentrates became available, and because of the end of the Cold War in Europe, at least, the concentrates became available equally in both parts of that continent. So that was the past, and what about the current treatment? On this time scale, you see the changes which were coming from the whole blood to the fresh frozen plasma, precipitate, cryoprecipitate, plasma concentrate, recombinants, and this is what we are living now, and this is what is waiting for us, knocking on our door. What is the factor therapy available, at least currently, from the European perspective? The current standard of treatment in most of the European countries are recombinant extended half-life concentrates at the moment regarding the factor therapy. You might ask, why recombinants only, or why extended half-life? The question is very easy. Because if you have all of the concentrate types available, there is no reason to administer anything else than extended half-lives, because the efficacy is at least the same as in standard half-lives, and the quality of life is much better. The only reason, at least from my point of view, why to give standard half-lives is if I want, for whatever reason, give plasma-derived concentrates, because they are not and never be extended. And secondly, if there is, for example, the pricing issues. If there are if there are those people who are making the decisions, the decision makers here, then I would like to comment very shortly on what we did regarding the pricing. We arranged that the treatment for the year should be somehow similar, whatever you treat with. In other words, if you come with something which is having twice longer interval, and you give 1/2 of the yearly dose, then it shall not cost more than twice as the original medication. With that approach, you can somehow leverage the cost, which will not be increasing dramatically over the time, and you can secure the treatment for your patients quite a long time. And what also will help a lot, and we, I believe, will have the time to discuss it tomorrow, is the importance of having your own data, so having the registries. But this is not the talk for today, it's to be discussed tomorrow. So we are currently using mostly the extended half-life concentrates, both for factor 8 and factor 9, and the advantage is evident, because you can either prolong the interval or increase the trough levels, or you can play with it. And what I consider to be quite important for factor treatment is its personalization. Because we know that the inter-individual variability in factor 8, mainly factor 8 pharmacokinetics, may be even bigger than 200%. But when I say personalization, I don't mean that you have to only change the dose, and that the personalization is only for the countries with non-limited resources. For me, the personalization is to use the most of what you have. So even if your resources are limited, even if you have limited amount of the factor, still you can adapt it for the best use in that particular patient, and adapt the dosing to his lifestyle, and vice versa, adapt the lifestyle to what the patient can afford. And to make it a bit more interesting, I would like to share with you some data of one of the PhD students who was focusing on pharmacokinetic changes in the childhood. We in principle know for ages that the pharmacokinetics is changing during the life. It is mentioned many times, but none of the studies, trials, or publications was focusing specifically what is that change. And this is just some of the data which have been sent to Hemophilia this week. And the objective for this was to describe these changes, trend and rate, and process it with the analytic analysis to find what is that change during the childhood using population pharmacokinetics, in that case particularly WAPS human. And this is just to show some of the results where every single curve or every single color is one patient, and it shows how it changes during the age, during the pediatric age of childhood. And it looks like every year it is prolonging for roughly 4%. Similarly for EHLs, and if you look on it from the different point of view, So if you put one dot as a one single measurement, you see the linear upward trend, which is similarly shown for both extended half-lives and standard half-lives. So what does it mean in practice? In practice, it just confirms that it makes sense to do pharmacokinetics in children every 2 to 3 years, because it is changing substantially, and if you want to get the most of what you have, you should do it regularly and repeatedly. This is not the case for adults when the PK is not changing that much. I was talking about factor therapy. So I was saying that we are using extended half-lives and recombinants, but what is the future for factor 8? In factor 9, we are not having that big trouble, because using extended half-life, factor 8 gives you the opportunity to inject once per 2 weeks, roughly, and it works well. We all know that the limitation of the PK of factor 8 is given by the half-life of von Willebrand factor. Because naturally, factor 8 is bound to von Willebrand, and it cannot overcome its half-life. That's the reason why the original extended half-lives were never really extended. There were several approaches how to change it, and that one really wants, and that one is currently available. And this is the modification of the molecule, where you take the part of von Willebrand factor, its fragment, bind it during the manufacturing process to molecule of factor 8, and then you prevent binding to natural von Willebrand factor, which is then overcoming the limitation given by von Willebrand factor. And this is the medication which is currently available. Originally, the study name was BIV001. Currently, or the name is efanesoctocog alpha. And with that change, you are able to prolong substantially factor 8 levels and its half-life. And if you look here, this is the standard half-life curve, the purple one. So the peak, right, going down, and a bit of tail. Here, this is the original extended half-life, still a bit better, but not that different. And this is completely different curve, which is showing rather the plateau for some time. And our patients on this, in accord with the literature, for first 3 to 4 days are having factor 8 over 40% and will never go below 15 or 20. And if I quoted here Professor Oldenburg, who has quite a big population of adults who are treated more frequently with this medication, then they never get below 40%. And 40%, this is not hemophilia. So even with this medication, you are able to get get rid of hemophilia, but still you pay some price for this. And these are the outcomes from the clinical studies, and you can easily see how dramatic is the decrease in the bleeding rate. And I just tell you that thanks to this medication and to emicizumab, which I will be mentioning in a while, in my country for last 4 years, the median ABR is 0 for any hemophilia of any severity of any type. So whatever hemophilia you have, being treated with one of these 2 options, you are sorted. And then, because I've mentioned emicizumab, so the non-factor therapy. And this is one of really, and you know it, because what I heard about your program here is confirming what I'm going to say. The non-factor therapy, and particularly emicizumab, is one of these revolutionary changes. We are now this picture, how it works, that it's mimicking factor 8 function, not being homologous at all with factor 8, which is giving the power to work in inhibitor as well as non-inhibitor patients equally. Similarly as in this country, it is registered and reimbursed for both patients with hemophilia with inhibitors and without inhibitors, and roughly you get something around 10 to 20% equivalent for factor 8 levels. We all know that in the beginning there were some issues with introducing this molecule, but I am deeply convinced that we learned how to use it. And at least to my knowledge and to the published data, the safety issues were sorted out, and the safety profile of emicizumab is currently very positive. What we are starting, and not only us, but also other groups are starting to use it more and more often also for type 3 from Willebrand, or eventually for acquired hemophilia. It works well too, but that's off-label. And again, to make it more interesting for you, I just would like to show you some of our real-world data. That's the second of the PhD students. This is the, well, at least when I was preparing it, it was like 60 patients, but currently we added 20 more, so currently it's over 80 patients, but the data are similar. I just did not redraw the slide because these other 20 or 22 were sent last week, so I did not redraw. My apologies for that. But having the most frequent scheme for emicizumab, the standard dosing, 3 milligrams per kg every 2 weeks. By the way, we were trying to give it once per month as well. It worked well, but the problem was that patients forgot to inject it. That it was quite a long time that they sometimes forgot to inject it, so we came back to every 2 weeks. And these are the results. So even though there was very good treatment before, the change to emicizumab led to substantial increase in the ABR or in the numbers of those who are having ABR 0. In other words, over 80%, 85 almost, of all patients are having ABR 0 on this treatment. And if you focus on joint bleeds, a JBR, or spontaneous bleeds, a SBR, the numbers are even higher. And this is nothing new because many other groups are showing it as well, but we are just confirming also on the real world data that it really works, and it works fine. And if you have no bleeds, no breakthrough bleeds, or very limited number of breakthrough bleeds, then you spare the money twice because you don't have to treat those bleeds. So the consumption of factor 8 or bypassing agents is down to almost 0. So it is some sort of extra saving you get for it. So that's the conclusion from these slides, showing that emicizumab works well. We are using it more often in pediatric centers. By the way, tomorrow we will be also talking about the principles of hemophilia care. And emicizumab is one of the things which is enabling to start the primary prophylaxis much sooner than factor 8. We will discuss it later on tomorrow. And the situation or the fact that it is more seen in adults is not that it would not work in adults that good, but because there are also, in pediatrics, there are also PAPs and MTPs who are hardly bleeding anymore. And what about the future treatment? I just show 1 or 2 slides because Professor Rastava will be focusing on rebalancing treatment and gene therapy, so I'll just touch upon this topic a bit. But we know the principle of the rebalancing treatment. if you are having a normal hemostasis, everything is in balance, procoagulants and anticoagulants. If you are bleeding, then the procoagulation is missing a bit, like factor 8 or factor 9. And what you normally do, that you add what is missing and you rebalance it. This paradigm is different. So there is imbalance and you do not add what is missing, but you remove something on the other side. So from somebody who is having the procoagulation deficiency, you make somebody who is having both procoagulation and anticoagulation deficiency, and to rebalance it on a new level. It may look a bit, how to find the word, like brave, this idea, but it works. And I believe that though it is completely different, it will have a significant role globally. For me, it is the treatment of choice for hemophilia B with inhibitors, for example, but in many countries it will be much broader portfolio. And this is just to show that if you go back 50 years ago to Inga-Marie Nielsen, who started to think about prophylaxis targeting trough level of factor 8, 1%, and compare it to what is today, so we are able to use the mimicking or the bispecific antibody. We are able to target the inhibitors of coagulation. Some of the suggested ways found to be like the cul-de-sac, the dead ends, but still it is evolving significantly. And just very shortly, this is one of the anticoagulation molecules. It's not yet in Europe. It is recently in the US registered, and that is the interference RNA, which is decreasing the transcription of antithrombin, but I'm sure that Professor Alok will talk more about this. And there are two more molecules which are focusing on TFPR, like that one, marstacimab, and the other one, concizumab. What is for me quite important, and I think that it will be discussed also in a few minutes, is that contrary to antithrombin deficiency, the TFPI deficiency as such is not a disease. It is not a described disease. So even if you are having TFPI deficiency, you are not supposed to have the international disease classification number, because this is not the disease, and it has some implications which Professor Alok will be definitely talking about. Last but not least, one or two slides about the gene therapy. Currently, we all know that we are using the transfection of factor 8 or factor 9 genes by the viral vector, most often AAV, so the adenovirus-associated viruses, and it has its pros and cons, but it is one of the relatively easy ways of the gene therapy, but it has its, let's say, difficulties or issues, mainly the transaminitis, which has to be treated. The gene which is used for the gene therapy in hemophilia A is very often normal beta domain deleted gene for factor 9. This is the gain of function gene. And the goal, the original goal for any gene therapy is to give once and that's it. We are not there yet. But, and this is not only my statement, but this is also, and I think I can say it as a EHAD president, as a statement of EHAD as well, that though gene therapy is not yet fully there, we should further support its development, because we believe that the future gene therapy, whatever it will be, because there are always many ways how to get there, is the future for the treatment. And whole community, whole hemophilia community is supporting further development. And it would be a mistake to stop it now. I've mentioned already transaminitis. It is something which is not wanted, can be treated, but it leads to certain problems even through the treatment itself. And this is the most important problem currently, and this is the reimbursement, because it is a new treatment which is quite costly, and the first piloting, or one of the first piloting countries, at least in Europe, is Germany, where they use some sort of leasing, like it works, I pay, it doesn't work, I don't pay. So it's like if you buy a car on the operational leasing. It has its pros and cons. It has to reach agreement between payers and those who are providing it. But currently in Germany, this is one of the reasons why very limited number of patients were dosed off studies. And this has to be overcome. And these are the two slides showing the outcomes from last DASH meeting, and you can see here, and again, because Professor Alok will talk about this in details, you can see here the much bigger inter-individual variability in hemophilia A gene therapy with the decrease in time, which is more prone than in hemophilia B, where the inter-individual variability as well as the decrease in the time is much lower. So what to conclude, or how to conclude what I wanted to say here? Non-factor treatment, and your country has, or Kerala at least, has a significant experience with this now, especially for hemophilia A, is definitely a promising way, which currently even compete with the GT, which may not be the case in the future, we'll see. No problems of inhibitors, so the nightmare of the past is sorted through it. No bleeding, no pain, but it is not a factor which might or might not be an issue for some patients. Factor therapy is not dead at all because it's evolving, and having those two cards in your pocket, you can play a very good game. Because whatever of these two you use, you will always win. And the gene therapy will probably solve the problem in the future, and further development is supported by the community. It may take some time, but a lot of has been already done, and we will hear about this in a few minutes. So after 50 years after the introduction of prophylaxis, we are witnessing major changes in the treatment of hemophilia. And these changes really are revolutionary. And every change is bringing a chance. And it is upon us if we will be able to use that chance for our patients, for ourselves. Thank you very much for your attention.
Thank you, Ian, for the very enlightening presentation and taking us through the evolution and the revolution of hemophilia and bleeding disorders. The session is open for questions and discussions. Can I start with a question? So in the era of emicizumab, when we had started using emicizumab, the expectations, of course, the bleed comes down, and children, especially when they start on emicizumab, they start performing better, and then ambitions are higher. And so earlier we used to restrict them from contact sports. We used to say no IM injections. We used to say no NSAIDs. We used to say no aspirin. Does that change in the era of emicizumab prophylaxis?
Definitely it does. Of course, we should not suggest to people with hemophilia to do dangerous things because they are still having hemophilia. But we all know the scaling of the different sport activities and physical activities, which are color-coded by the green, yellow, red. So in the past, we were focusing only on those green ones. Now we are very happy with the yellow ones as well. And in practical world, it means that we are not restricting our patients or our people with hemophilia to do the regular activities, and they do not do it. Of course, I would not recommend to anybody like this to go for rugby training, but we are having all the general physical activities which are people doing without any breakthrough bleeds. There will always be an exception, but in principle, there is a lot of literature published that should you are over 12 or 15% of factor 8, you hardly bleed. And with emicizumab, you are getting in the dosing diagnosis, you are getting the equivalence which is very close to that. So it very well fits that, and this is our current policy. We do not discourage our patients, both adults and children. In children it is much easier because their joints are pristine with that treatment to limit their lives apart from very contact sports or from very dangerous activities. So our children are also skiing, doing football matches, and everything works well. Of course, it still has to be the responsibility of that particular patient to take the good care of his or her health. Because the role of the doctor is not to say what the patient should do, but to give him the information, to guide him with the medication available through his or her health.
What about intramuscular injections, vaccinations?
No problem with that.
And in older patients, especially in adults, there are emicizumab antiplatelets.
This is something which I would rather refer to the recently published guidelines. There are two of them. One are from the Roger Shugyan's group, and the second one which was published last week, and it's the several European associations, starting with the Cardiologic Association and others, including EHAD, Robert Klamroth and Fatima Chudari were representing there, and Rosalind Doivron. And this is a bit more difficult. We do not have the data that emicizumab should be enough to be given solely and enabling the dual antiplatelet treatment. On the other hand, you will find some data where this is described, but it is not at the stage where you can recommend it. So definitely, it is more easy than to keep the factor levels over 20% with the factor, but to the knowledge which is available to date, we cannot recommend to say that if you give emicizumab, you are safe for the dual antiplatelet treatment.
And if the other question is about if you are on emicizumab and then you have to perform a procedure while on emicizumab, and then a minor procedure or a major procedure, how do we do it and how do we monitor?
It depends on what kind of procedure it is, and you know it better than me with your patients. The minor procedures we do without any other medication upfront, and we only use the factor if the bleed appears, which is very unlikely. In the major procedures, we combine it, but very often 1 or 2 doses maximum of extended half-life concentrate is enough to stop the bleeding, and this is significantly easier to do it than with the previous treatment. And because we know that combining emicizumab plus factor treatment is not an additive one, because if you give factor, the emicizumab for that particular time is out of the game, and then it keeps the level once the factor lowers down. So it is safe, and it's significantly, at least in our experience, and this is the same what is published, it is decreasing the number of the infusions and the consumption you have to use for the surgeries.
So if I understood it correctly, if for a major procedure you have to give a complete 100% factor so that it should be covered by factor.
Having emicizumab doesn't mean that you would decrease the the dosing of the factor. So if this is the procedure which needs 100% of factor 8, you should give 100% of factor 8, even if the patient is on anesthesia.
In such patients, is there a risk of when patient is on both factor 8 and emicizumab? In the real world experience, is there any increased risk of thrombosis?
Well, then go to the literature, I suggest. But as I've said before, as this is not an additive effect, the risk shall not be increased. This is not true, for example, and I think that Professor Arnold will talk about this with the Valencian treatment, where if you add something, there is an additional effect. And the same is for patients with inhibitors. So if you give emicizumab plus bypassing agents, that's completely different story because there is an additive effect. But we could have a symposium about the thrombotic risks of patients with hemophilia. And even in the real world, there are patients, there are colleagues like, for example, already quoted Robert Clamrod, who would never give low molecular weight heparin for any of the hemophilia patients whatsoever, unless having sky-high levels. We are, for example, using low molecular weight heparin. So I don't think there is any strict guidance on this, and I just rather refer again to the recently published guidelines, which are dealing with the both anticoagulation and antiplatelet treatment.
How much guidance you seek from the laboratory in terms of shaping the treatment?
And this is very, very important. Thanks for this, because you can have the excellent medication, but unless you have the excellent lab, it will never work. So if you are using especially emicizumab, you have to be pretty sure that you are able to measure the activity of factor 8 if you are concomitantly giving it. We are also checking the levels of emicizumab, but this is something which we do for because we like it. There is not any proven relation between the level of emicizumab and the level of protection. And this is why we, for example, use also, and I've mentioned it there, the whole while rounding. So we don't necessarily have to go precisely 3 milligrams. We go either low or down based on the vial size.
So if you have any experience of treating slowly or hemophilia?
The major experience currently in Europe is in Brussels and in Germany, and these are people who are having quite like tens of patients with acquired hemophilia treating with emicizumab. The reason for saying is that they are able to avoid immune suppression, but it means that you have to sometimes almost indefinitely treat with the emicizumab, because if you do not give the immunosuppression, then the inhibitors are still there. You can cover it with emicizumab, but the inhibitors are there and could be there for ages in some patients. So the benefit of this is that, and we did it the same, recently there was an older lady who was coming with the acquired hemophilia, so she upfront started with the emicizumab. There is some recommended dose for this, still off-label, so you give the bigger dose in the beginning, like 6 milligrams per kg, then you go to 3 milligrams per kg every 2 weeks, and it worked. It worked well. And especially, but that's purely my opinion, especially in the elderly, where you are afraid that the immune suppression could jeopardize the health or the life of the patient, this could be an option, and some centers are using it like this.
Thank you, sir, for that very illustrative session. So I have one doubt. At what age do you start prophylaxis? As soon as a severe hemophilia is diagnosed, or at a later stage after everything agreed? And in your slide you had shown that the oldest patient is 79 years on the emicizumab prophylaxis group. So is it a lifelong prophylaxis? in your country?
Yes, there is a primary prophylaxis which starts currently, if it is started as factor, then it starts within second year or not later than during the first 2 years of life, not later after the first bleed, whatever appears sooner. And this is the factor treatment. So all of our patients are on primary prophylaxis, and there is no limit, no age limit for it. And it's obvious because once you invest into the prophylaxis in childhood and you stop it in 18 or 19 or whatever, the money are almost lost. Indeed, during the growing phase, the bleeding is more frequent and the children are not that careful as adults could be, but still you would invest a lot and you would at least practically lose all these investments. So we are not finishing it at a certain age, but we did it in the past as well. Every country did it, because you have to, firstly you always invest in children and then you invest in adults. And you have to do it stepwise because it costs some money, obviously. But what we see is that it happens anyway, because once those children who are starting on prophylaxis get to adulthood, they will not want to stop. And with emicizumab, the only change is that some of our children are on emicizumab from the very beginning, and some of them are even from the newborn age. Like there was a risk for intracranial bleed, and this is seen from the data of PEDMED, that the intracranial bleed in neonates and infants, 30% of these bleeds are happening within first 3 months of life. So it makes sense to start the prophylaxis sooner. Before we were not able to do it because nobody wants to inject twice per week the baby. And it would need to have the central venous lines in it. But with emicizumab we can do it.
Question? Standard doses or at any?
We use 7A. We don't use APCC, or we didn't have to use APCC. Now you also find in published literature the data of the groups which are starting cautiously to use APCC in those who were not responding to 7A, but we didn't have to do it, and we strictly follow the SPC so far, so we are using 7A, and we are using it in a lower dose. Up to 60 milligrams per kg.
In my experience, so many adults and children who are maintained on a wild strength-based dose are doing well without increasing the dose. We used to give only standard prophylaxis, standard dose. And a few papers have also come. So what is your opinion regarding the low dose?
Low dose prophylaxis is something which has which has dramatically changed the landscape in the factor treatment in the past, because we all know that the low dose factor prophylaxis, though it is not for 100%, it still makes a significant job, and it is very similar for emicizumab. So we do not have the experience with lower dose because we don't have to. But for example, what we do sometimes is that we found that once you start with emicizumab, it really starts to act within children. I'm a pediatrician by background as well, so I treat both, but pediatric is more closer to my heart, I would say. That even if you skip the loading dose, it starts to work within the first 5 to 7 days. And it is not that good as if you use the loading dose, obviously, but you can do it. And it is some sort of shortcut to what you've asked. So even if you give the lower dose, it still does the job. I'm not advocating for it because it is off-label, it is not in the SPC, it must be on discretion of the treating physician. But to me, it is, and you have more experience than me in this. So it is definitely something which worth. And if you can serve more people, then it is a good start. And sooner or later, hopefully with the programs you are preparing, you will be able to give a few drugs. But it is always good to do a step than to wait. That's my opinion, and my view of it.
I'm very sorry that I'll have to stop you. Probably the last question.
No, I just want to thank you, Anne, for a wonderful journey through the history of hemophilia treatment. You made a strong statement that if you have the ultra extended half-life and emicizumab, you can manage any hemophilia. But what about all the factor 9 deficient with and without inhibitor? You did mention with inhibitor you have only one option at the moment. But I think, while we are celebrating the factor 8 advance, do you want to comment what you do with your factor 9 non-inhibitor?
Yeah, with factor 9 non-inhibitors we are using extended half-lives because this, what we call super extended half-life in factor 8, is almost equal to what is the standard or the typical extended half-life. So thanks for asking this question because for me, hemophilia A, with this medication which is available today, which I administer once every fortnight, it is absolutely marvelous. It works very well. And we are now even starting to, in a similar way as in hemophilia A, starting also to think about the mild or moderates with the bleeding phenotype. Because what we see from registry is that those with severe hemophilia are relatively well treated. The problem is moving upwards, and those who are having the bleeding phenotype, not having severe hemophilia, are underserved, and we have to focus on it. And with the medication you've mentioned, it is possible. And we currently, for example, are having this study with marstacimab as well. So it was 2 weeks ago when the family came, and they were so scared of needles, like really very much. So we offered them the study, but I would not push them. It was just an informed decision. I was telling you, either once per fortnight or once per week subcu. It's your choice. We will guide you through this. Both are equal, and I personally have more experience with extended factor 9 extended half-lives than at the moment with the rebalancing.
So I'll request Dr. Neeraj for one more minute because a very important issue was raised about surgery on emicizumab, and we will debate this during our panel discussion with what Dr. Ian Blackney said. But I want to ask him, the 100%, how do you monitor with what tests in the lab? Do you assay at all, or you give the dose and do no assay?
Pardon me, what?
You're giving 100% factor 8 replacement.
Yeah.
How do you monitor with what assay in the lab?
Yeah,
and how does that apply in the world, even in Europe?
With the chromogenic profile.
Yeah. So, if I then asked you how many labs in Europe can do chromogenic bovine?
Currently, it is all hemophilia centers in the world. But there is because otherwise we would not be able to treat it. I would be really afraid to treat, not able to monitor this.
We must understand that very critical step.
Yeah, so this is it, and because the network of the hemophilia centers is not that huge in small countries, so this is 6 labs in the whole country who does it.
Thanks, yeah, thanks everybody for the fantastic discussion.
wonderful session on the evolution of hemophilia. We move on to the next topic, that is emerging therapies and future of hemophilia management in India. And we are lucky to have none other than Alok sir. And we all know that sir is teacher unparalleled. Because even before I did my DM in hematology, I had this chance, and I regard that as the biggest, luckiest factor in my life, to attend sir's 1-week training in hemophilia in CMC Vellore. And that has been the basis of whatever I know about hemophilia today. And this is the same with most of the other hemophilia treating doctors all over India. And the past, present and future of hemophilia in India has been shaped by the concepts which are developed and expanded by sir. And the latest gene therapy trial which was published in NEJM 2012, that's also a proud moment for all of us Indians. So to hear from sir, we are really waiting to hear from sir about all of this.
Thank you, Dr. Hikar. Thank you, Dr. Neeraj and Dr. Rahul for making me a part of this program. You know, today is a very significant day in many ways. I was just thinking as Dr. Blackney was talking about evolution and revolution. It was 1988 when Mr. Ashok Verma landed up in Vellore, traveled all the way from Delhi, and said he is not getting enough medical support for the Hemophilia Federation India. And so he had to travel 2,000 kilometers to come and find us and say, can you work with us? And that's how it all started. And hemophilia was a very low-cost platform. We met in medical colleges, community halls, low-cost places. So part of the revolution also, to me, is that we are meeting in the Marriott today, and we're talking about universal prophylaxis for all children in at least one state in this country. Yesterday, I was conducting a panel discussion in the HFI meeting, and we had panelists from 7 states. And one state in the west of the country, Gujarat, is offering prophylaxis to everybody. I was surprised, severe, moderate, mild, everybody, if they agree. So, it just tells us that if there is understanding, there is no lack of resources. And if there is support from, if there is a demand created by the healthcare professionals and the patients, and there is an understanding health administration, as is obviously happening in more than one state now. It's not just Kerala, but also probably in Gujarat. So it's a question of, and there was contrast. There were other states, and maybe Mr. Prem will talk about it later tonight or tomorrow, about all these things. But it's actually truly revolutionary. So anyway, Dr. Neeraj wanted me to talk only about gene therapy. And I said, it's too much in the future. There are other important things coming much sooner, and it's important that we discuss that also, so that people, it takes time for us to understand, and Dr. Jan Blackney has already introduced some of these new therapies that are likely to arrive much sooner than gene therapy. And so I thought today I will just take you rapidly through some of the very brief history, because already a wonderful job has been done. So you're all familiar with this, and Dr. Blackney actually pointed this out. So I'm going to really concentrate on the right end. You already heard about the standard half-life, extended half-life, and emicizumab, and I will not repeat any of that. But how are we going beyond that? And that's what we really have to talk about today. So before doing that, I just wanted to remind, maybe that reminder is not needed in Kerala anymore, but because you already accepted prophylaxis for all children. But please remember that prophylaxis is needed for all PWH. And as again pointed out, it's a very good thing to start with prophylaxis up to 18 years of age, but you want to give it to everyone. And then of course you look at how much resource you have, and how do you tailor that so that many more than only people up to 18 can be covered. And that's where dose calculations and product selection comes in when you have more options. Right now, those options are limited. So this unequivocal statement was added in the third edition just to leave no doubts in anybody's mind that we will not in the world again ever say that episodic or on-demand treatment is a long-term option. We will only recognize it as a necessary step for breakthrough bleeds, trauma, or surgery. Other than that, we will not say that episodic treatment is an option. So in fact, right now we were discussing last week updating of chapters 6 and 7 of this as living guidelines. And I can tell you that in the structure of the table of contents, somebody had put, just for discussion, prophylaxis and episodic, and I said, don't ever do that. Even in the content, it should not look like these are two equal options. It just has to, disappear from the content and come as a statement that if you bleed on whatever treatment you are. I also wanted to say, now that you're doing prophylaxis, you must have a good understanding of the definition of primary, secondary, and tertiary. I will discuss this again maybe during the debate, but I tell you, even in Europe today, there's almost nobody who's getting primary, if you look at the definition carefully. Because, at least in terms of factor replacement, because this definition was a very puritanical definition that only Malmo was following. Even in the past, no European center was doing this. Why I say this is, Malmo was the only one trying to start prophylaxis before the first bleed. So first of all, to pick up the natural history of milder phenotype in a severe hemophilia, most people waited for the first bleed, and that's what Dr. Blatney also said. The definition of prophylaxis is regular replacement. So we struggled a lot to come up with this definition 10 years ago. So you have one bleed. Now you call the family and say, hey, you have to counsel them, they have to accept it. You don't start 3 times a week or 2 times a week straight away. They have to start maybe once a week, once in 2 weeks, then slowly it will build up. By the time actually we have data, PEDNET data, which shows that by the time everybody got onto the regular prophylaxis, they would have had 2, 3, 4 bleeds. So but no musculoskeletal damage. And that is why today almost everyone in the world, even in the West, falls into the category of secondary prophylaxis by this definition. Whether this definition is good and needs to be changed is another matter. But hardly anybody. So when you are doing this, you must record it accurately, and that's why I put this slide up here, that please understand what the finer nuances of the definitions are, and your recording must take care of that. The next part, which I don't have time to emphasize today, is everything is on patient-reported bleed. And what you call a bleed, particularly a joint bleed, not bruising and all that you can see easily, but what you call a bleed is a very big challenge. And now that again you are doing this wonderful prophylaxis for everybody, please make sure that you spend a lot of time educating yourself, standardizing the leaders here, but also the teams. Nurses, physiotherapists, whoever is reporting what is a bleed. Otherwise, you will land up recording all kinds of events as ABRs, and you will have issues with the results, the outcomes that you get. Again, won't go into this at all, but we will leave this. This one only mentioning, just to remind that as you celebrate the policy of emicizumab prophylaxis for all children up to 18, please don't forget the factor 9s and make sure that you acquire some long-acting, because as Dr. Blackney just mentioned, the long-acting factor 9, and thankfully there are some available in our country already. So you have to offer that to people with factor 9, and luckily factor 9 with inhibitors is a very small number. So, but if you combine the emicizumab with the factor 9 prophylaxis, then you're truly covering nearly all hemophilia, because all the factor 8 inhibitors are covered with emicizumab anyway. So the children with factor 9 deficiency, if you don't give them one of the long-actings, then they have been left in the cold. This was mentioned already. This is doing amazing revolution so I will not mention this anymore. But as was mentioned, if you give it once a week, you can maintain 10-20% baseline levels. And if you can do that, but remember, we never get away from inhibitors if you use factors. So that's a conundrum that the world has not sorted. On one side, we would rather replace like with like. You're missing a factor, replace the factor. But the moment we give factor in any form or shape, we just don't escape inhibitors. So that's a real problem. There are always pros and cons of using non-factor. There are a lot of discussions about the other roles, other functions of factor VIII, and if you don't give that, will there be an impact on other organs in the body? But we don't know the answers to some of those things. But this is amazing for those who don't get inhibitors. So this brings us then to, and you saw something like this that Dr. Blackney also showed. You have the mimetics on the left. Emicizumab is already there. Mimate is following closely. Maybe in 6 to 12 months we might see it becoming available. And there are some more advanced versions. So the mimetics are there to stay, and they're doing a great job in revolutionizing factor VIII deficiency management with without inhibitors. On the other side, what you see are what's called the rebalancing agents, and I'm very glad that Dr. Blackney already explained the concept. So most of us don't think about thrombosis and the natural anticoagulants. We did measurements of antithrombin and protein C and S, so at least we knew the names. TFPI was a real unknown entity, and it's probably so crucial in physiology that if you have serious deficiency, you will not survive, and therefore I have never in my life made a diagnosis of TFPI deficiency causing clinical thrombosis and tried to treat such a patient. We don't even have a regular assay for detecting that. So it's obviously something that nature doesn't permit for, in life. But people were experimenting and trying to see what happens if you reduce. And when this research started maybe 15, 20 years ago, we thought of some of these as maybe adjuvants. We never realized that they could become so powerful in terms of inducing hemostasis as we are realizing now. So as was already mentioned, your two drugs, concizumab and marstacimab, and in the last few months, all of these have been approved. And even fitusiran, which is now trying to attack antithrombin by a complete. So those two are monoclonal antibodies, and fitusiran is an siRNA, which affects the mRNA translation into protein. And therefore, you reduce, but with whatever mechanism, you reduce these levels. So by reducing the levels, this I will skip totally because this has been very well covered, so we will not get into this. But certainly it was revolutionary to see this, so I'll skip. I'll come to this. So this is a cartoon we created when we were trying to write a commentary on the concizumab pivotal data for its registration. So again, emphasizing the same thing, but this time making it a little bit more specific in terms of the cartoon. You have the important procoagulants in blue, you have a whole list of anticoagulants in red, and that's how we live normally. Now, the next one, if you have 8 or 9 deficiency, you can see that the blue side is getting lighter, and therefore the red is becoming heavier, and you bleed. And to treat that, we just replace the 8 or 9 and try to balance it again, and we achieve hemostasis. But what if you just knocked off the red? And that's what we are trying to do here. So we are knocking off TFPI so far only with monoclonal antibodies that are designed towards anti-TFPI, and the antithrombin by different mechanism. You have DNA, you have RNA and protein. The conversion of the RNA to protein is being affected by the siRNA. And so the level comes down. There's no antibody in. Now there was also an anti-APC, but recently it got withdrawn from research because it wasn't looking so promising. So people are trying to affect the right side as well, and with that, as I said, it's quite surprising the level of hemostasis that has been achieved. And what I'll show you next in about 6 slides, 2 for each of these products, is the kind of study design. So now regulators and society are more demanding. In the past, if you look at the initial recombinant product trials in the 90s, mid to late 90s, they only did a replacement for episodic bleed, and it was judged efficacious if with 1 to 2 doses you had resolution of a bleed. That's all that was there in the literature. Now we require comparison between episodic and prophylaxis, and we look at ABRs. So don't worry about this big design. The important thing is they have all studied 200 to 300 patients, not 30, 40, 50 patients. They have been evaluated for about a year or so on the study, and then they all have extension studies that go on for 2 or 3 years or longer. And they of course look at very carefully the spontaneous bleeding, the joint bleeding rates. So with that kind of study design, what are we achieving? What we are achieving with these products is less than 3 bleeds. The zero bleed numbers are not as high in some of these products. So from a regulatory perspective, this is significant enough, very convenient because this is also subcutaneous, not intravenous. In this case, it's once a day, concizumab. The same manufacturer as the age-old insulin. They have the same pens, wonderful, so you take once a day. It gives you an option. And these are universal products. So hemophilia A, B, without inhibitors, same drug. Okay, that's concizumab. Marstacimab is very similar, evaluated again extensively in multiple cohorts, and the long-term study is still ongoing. And this again gives you, a little more bleed, but much reduction compared to no treatment. So the episodic arm compared with the prophylaxis arm gives you enough reduction for the regulators to say this is a significant drug. So all of these have been approved. They're already being used in some countries. They will slowly come. We hear that Pfizer is thinking of bringing marstacimab to India. I think the real world data will really determine how effective they are compared to some of the options we are currently using. But they were significant enough to get registration. Fitusiran being a different mechanism, so as already explained. Now, the siRNA is easy to manufacture. How do you push that siRNA into the cell where the protein is being made? So antithrombin is generated in the hepatocyte. So how do you make sure that subcutaneous siRNA will go to the hepatocyte and not just roam around in blood? So you tag it with what's called a GalNAc moiety. So the acyloglycoprotein receptor on the hepatocyte will attach to the GalNAc to which the siRNA has been tagged. So there is siRNA, you attach a GalNAc moiety to that, and this GalNAc will go to the ASGPR receptor on the hepatocyte. So this is what makes it specific. It doesn't roam around anywhere else. So a small dose injected subcutaneously reaches the hepatocyte and starts reducing the antithrombin levels in plasma. And again, the surprise was that just by reducing the antithrombin level, how much hemostasis can you expect? Okay, we had case reports earlier of people with antithrombin, protein C, protein S deficiencies with hemophilia who had a milder phenotype. They didn't stop bleeding. So I'm not sure we fully understand how this anticoagulant reduction is so effective and in achieving hemostasis, and I'll tell you why I'm calling it so effective. So this is again, design. This is probably a drug that has had more phase 3 studies than any other drug in the history of hemophilia treatment. So first 3 phase 3 studies, and here they were using a higher dose of 80 milligram once a month, and you can see that the ABRs were all 0 here. In the middle you can see that. Now they had very low, less than 15% antithrombin. There were few thrombotic events. So if I'm treating a bleeding disorder, my goal so far when I was using factor, standard or extended half-life, or even ME unless we combined it with APCC, was to somehow stop bleeding. Did we ever make a bleeder into a thrombotic by giving a drug before? No. So if I can use a drug to make a bleeder into a thrombotic, should I be happy or unhappy? I'm happy, I'll tell you. I'm happy because I can dial, and because now I have such a potent drug, as long as there is enough therapeutic window. If there is no therapeutic window, then it goes out of consideration. But now finally I found something, and this is true not only just with fitusiran but all the rebalancing agents. There's been some thrombosis with all of them. Okay? And therefore they have all done some adjustments. And actually the subsequent studies with fitusiran were all about adjusting dosage. So now they came up with antithrombin guided protocol, and here they reduced it from 80 milligram once a month to 50 milligram once in 2 months. And then depending on the response, we won't discuss this now. The day it comes to India, if it does ever, we will talk in more detail, but I just wanted to introduce the concepts. So here now again you get, you see on the right side that with the antithrombin level directed dosing, where you start with 50 milligram once in 2 months, once in 2 months, and then you go up or down depending on the antithrombin levels, which they are now targeting 15 to 35. You finally get again that 1 to 3 bleeds per year, and that's considered good enough for the regulator 2 to 3 weeks ago in the US to approve this finally after the largest number of phase 3 trials, as I said. So that's what you are seeing. So when you have people on these drugs, obviously they may still bleed. They're not zero bleeds, all of them. So how do you replace more? The basic guidance is that they will require lower doses of replacement. If you give too much, then you could get thrombosis, and you need to be careful. Because there is a baseline hemostasis, even in people with inhibitors. So be it bypass agents or be it factor 8 or 9 replacement, you have to use them at lower dosage. And all these manufacturers have come up with bleed management guidelines or breakthrough bleeds on this. So I just thought, because Kerala is so progressive, when this comes, I don't know when your next Chakravyuh will be, in 1 year or 5 years. You'll certainly have these products with you before that, and you may consider introducing them. And if you're introducing them, then it's important to understand some of these concepts as you apply them in your practice. So that's all for that. Now we come to gene therapy. So in the classical sense, gene therapy meant some gene is not functioning, that protein is reduced or absent, and therefore you introduce a normal gene, and we have enough molecular biology capabilities to construct a normal gene, which we call a transgene. So you have a transgene. Now this transgene has to be carried by somebody, and that carrier is the vector. Could be a viral vector or a non-viral vector. And then it has to reach the cell of interest, because not all our cells carry our entire DNA, which has all the genes, but only some genes are expressed in some cells. So the intracellular machinery of each cell is designed to express certain proteins. In the case of factor 8, it's the endothelial cell predominantly and the megakaryocyte, as you know, and for factor 9, it is the hepatocyte. So here we have to, if it's a factor 9 gene therapy, we were fortunate to try and target the hepatocyte itself. So it was the natural cell that made factor 9 that we were targeting with whatever vector, and we'll come back to that. In the case of factor 8, we didn't know any better. We found one cell that was willing to make factor 9, and so we said, okay, let's make this fellow make some factor 8 also. So we pushed the factor 8 gene also into the hepatocyte through similar vectors, the AAV vectors. Okay? So we push it there, and if it goes there and functions, then it will make the protein. It has to secrete it. The protein has to get out of the cell, because if these proteins sit inside the cell, then it will be toxic to the cell. So remember these concepts, and with that, the question next is, how much do we need? So already you heard the first 2 data sets, observations in Sweden, told us that if you can somehow make it more than 1% for people with hemophilia A, then, with people with hemophilia, if you make it more than 1%, then their bleeding rate, bleeding phenotype is significantly altered. And that was the basis on which Ingemar Nielsen and Van Creveld taught us 40, 50, 60 years ago that you should do some prophylaxis. Then came the data on only about 500-600 patients from Utrecht, where they showed that 10 to 12%, and that's the number that was mentioned earlier, makes you well enough to do normal activities, maybe some non-contact sports quite easily without fear of spontaneous bleeding. And then the very interesting data from the CDC in USA on the right side, where they tried to see what is the level at which the bleeding profile tends to match the normal population. And that number is somewhere in the 20 to 30% range. So when we're trying to do gene therapy, human beings always want more. So go back, those are the numbers to remember, 10, 12, 20, 30. If we are, depending on what you are aiming, at one time even 5 was celebrated, but now that we have other products, 5 looks very bad, and I'll tell you why. So hemophilia of course becomes a good model because you can see that changing from 0 to 1 is a big deal, changing from 1 to 10 is better, and changing from 10 to 30 is close to cure. So it's an amazing disease where whatever you achieve will be good. So now how do we actually do this? So there are 2 broad approaches for gene therapy for any disease in the world today. One is the in vivo, and there you have a bulk manufactured product, vector with the transgene. Some pharmaceutical entity manufactures it. Usually it's a frozen product. You bring it, you test the patient, make sure they are eligible to receive it, and it's a simple intravenous infusion, and the vector here that predominates is the AAV, adeno-associated viral vector, different serotypes for different diseases, including SMA that more than 250 children have been treated in India, right? So that's AAV9. In the case of hemophilia, it's so far been mostly AAV5 and 8. There are other variants as well that have been used. So here, bulk manufacturing, easy administration, and so far, good safety profile. No major toxicities related to this. Except, there are major challenges. There is highly variable initial expression. There is decline in factor VIII, particularly after 6 to 12 months. And ineligibility can be very high in populations that have anti-AAV antibodies. So some of these are advocating no need to test, but even there, if you have beyond a certain titer of anti-AAV antibodies, it can be very, you will be ineligible, or it will be ineffective if you are treated. Our studies from India, I'm not showing you the data today, anti-AAV antibody serology for AAV3, 5, and 8 is in the 50 to 80% range in the population. So we realized a long time ago that even if we develop, and we are still trying to develop AAV gene therapy, we may not have a lot of people eligible because of pre-existing anti-AAV antibodies. So the other concept is this one. This has been used for 25 years now, roughly, starting with immune deficiency disorders, SCID, and then other immune deficiency disorders, and the last 10 years for major hemoglobin disorders, thalassemia and sickle cell disease. Now here what you do is that you take a cell out, take it to the lab, you insert the gene in the cell in the lab, and then you transplant that cell back. Now conceptually this can be done with many cells, but so far the easiest one has been the hematopoietic stem cell, and for all the immune deficiency and major hemoglobin disorders, that has worked very well. So that concept, here you have no age barrier. I forgot to mention, a very important thing mentioned last under the AAV is the age barrier. Because it is liver directed, you want the liver to grow to an adult size almost before you treat. And so for the first 10-12 years, you can't do gene therapy, you have to treat with something else. And that's a major challenge in many parts of the world because effective prophylaxis is not available. So in the other case, you can actually treat at birth, maybe 6 months, 12 months. We do transplants allogenic, as you know, for children at 6, 12 months. So what's an autologous? So easily at 1 to 2 years of age, this could be done theoretically. We haven't got there yet. There will be no anti-AAV antibody barrier, but This is highly complicated in terms of technology. Because you have to take the cells out, that's pretty easy. We are doing apheresis in all kinds of blood banks and centers, and we can collect stem cells. But beyond that is the very major step. You need a lab that can transduce these stem cells with a vector. And that is almost like CAR T cell manufacturing that all of us are becoming more and more familiar with. But so far, automation of hematopoietic stem cell transduction has not been standardized on any platform in the world. So there's a challenge there that has to be done in a very skilled lab. After that, you have to do a transplant. Now, the transplant is a very big deal. I mean, most, particularly in the West, here we hematologists are kind of, general hematologists, because we do oncology, we do non-oncology, and we are familiar with these things. Transplant is not a deathly word for us. But for people who do only hemostasis and non-malignant hematology, you say, you have to go and transplant your patient and say, are you out of your mind? This poor guy has only got hemophilia. Why should we transplant him? It's only for cancer. Or some, other genetic disorders where there's no other treatment. So there is a mindset that we have to work on. So, we started our efforts at developing gene therapy for hemophilia almost 20 years ago, in 2003-04. It didn't go anywhere because we didn't get approval by the time, it took us 2 years to get a response from a regulator, so I keep showing this slide that it should never happen again. We finally, in the world, about 10 years after that, this was the first gene therapy using AAV8 at that moment. We were trying to do the one, was AAV2, this was AAV8. And this is what I said, 5% at that time, this was published in December, and the editorial in the New England Journal says, Merry Christmas for hemophilia B. Okay, 5% was good at that time in 2011-12. There was no imicizumab, the extended half-life was just about coming in, it had not been approved, so 5% looked very good in 2011 to 14. But after that, all these other drugs that you heard about, now who cares about 5%? You don't want gene therapy that gives you only 5%, you want more. So 5% is unlikely to be acceptable anymore. So come forward 10 more years, and in 2022, the first factor VIII gene therapy with AAV5, Roctavian, gets approved. You see here on the left the high variability. You're getting expressions in the beginning from 50 to 400%. People were really worried some of them will get thrombosis. Occasional ones, not in this study, but in some other study, they did get thrombosis as well. So you have to really watch for this. So this initial variability followed by decline in factor VIII. And this is showing you the 5-year data. You see at 200 and 250 weeks, it is coming to somewhere in the 5 to 15% range, roughly. That is not again looking so exciting. But anyway, this drug got approval, and I'll come back to that, what happened. Factor IX, on the other hand, is much better, much more stable. 2 products. Without getting into details, these 2 products got approved. One is the Hemgenix, other is the Bequase, and they came into the market between 2022 to 24, and at a cost of $2 to $3.5 million. At least the list price, nobody pays this price, they all negotiate. It goes maybe half or less of that amount, but it's still a lot. But this is what happened. Unfortunately, in the last 5 months, we've had some real bad news here, because Roctavian, the uptake, it was launched in Germany in 22 September, and even in Germany, it's just about 10 doses maybe, 15 doses, I don't know, Jan may have 4 doses. Yeah. It's as low as that. And some 15-20 patients are being screened for a long time. There are challenges. In the US, about 20 doses. So the company BioMarin has officially declared only 3 countries in the world they will market. USA, Germany, and Italy. So, that's not really a successful product. Then the Hemgenix is still there, but the number of doses sold for Hemgenix is also very low. And Bequase has been formally withdrawn by Pfizer. It's no longer in the market. And some of the others, Spark and Roche, have terminated certain studies. Some more have been terminated after. So the AAV-based gene therapy somehow is not looking that exciting in the world for various reasons that we just discussed. So we come to our lentiviral, and here, for reasons as I mentioned earlier, I knew this AAV serology was going to be a challenge for us, and because for us transplant is autologous transplant is, for those of you who are trained here, we say our students will do it in their garage. So it is really, not something that we think much about. But the technology, we collaborated with Emory University. What we did was essentially, without getting into details, we put the factor VIII gene into the hematopoietic stem cell with a promoter that will express it only in a differentiated cell, not in the early cell. So a monocytic cell with CD68 expression. And with that, you take the person, you mobilize stem cells just like normal. You take it to the lab, we develop the skills to do the transduction in the lab, check that you have put enough copy numbers of the vector of the transgene into the hematopoietic stem cell. So it's called vector copy number. You expose the hematopoietic stem cells to this lentivirus, which is carrying the gene. The lentivirus infects the hematopoietic stem cell, inserts the gene into that, and then you use that to do the autologous transplant. So these are the inclusion-exclusion criteria. Basically, adults with no inhibitor, 18 to 45 years. We actually wanted to use older patients. And we had a community meeting with all the chapters of the HFI in Tamil Nadu. And they said, what is this? Why only 30? Make it 18. Because younger people want to do this. So actually, based on that request, we put a protocol variation based on the request from all the patient groups that it shouldn't be 30, it should be 18. And then you will see that we actually got one young person. So we collected enough stem cells, we kept an aliquot unmodified because if something went wrong, we wanted to rescue the people. We used a myeloablative conditioning, and then we did the manufacturing. Again, I don't want to get into details. We did one manufacturing protocol that was given to us from Emory University, and the first 2 patients were treated with that protocol. That gave us expression, and that's good, that's a good thing. But we then found that the expression was not high enough, so we modified the manufacturing protocol, and if there is time, we can discuss it. So these are the details. You see, the patients were 22 to 41 years old, and they had large number of bleeds, 20 to 50 bleeds per year. They were all severe hemophilia. We got enough stem cells, and we treated them. And again, this is not a transplant group, but for those who are familiar with transplant, will see that these are amazingly short durations of cytopenia with no major 2 toxicities. The 2 toxicities that dominate gene therapy discussion with transplant using busulfan instead of triosulfan is severe mucositis that people are suffering when they get transplant for thalassemia, sickle cell disease in USA, and the infertility issue. And both of these, and this was hardly any mucositis. This is the first evidence in the world of autologous transplant with triosulfan, surprising even for us how simple and easy it was. And the fact that the sperm count, we did actually sperm banking for all these young men, but 6 months after the transplant, all of them had recovered their sperm count. So this was again a major surprise for us. Finally, the efficacy. This is being true even now. All these patients, those are the ABRs, pre-gene therapy. The ABRs post-gene therapy are really very low. And how was this achieved? So as I said, the first 2 patients, thankfully were not zero. When you do a phase 1 gene therapy, so far, in no phase 1 gene therapy for any disease, as far as I can see from the literature, has the first 1 or 2 patients responded. They didn't have any toxicity. It was a safety feasibility study always, and they didn't have toxicity, but nobody showed a response. We were fortunate that the first 2 patients showed response, and with the 2 to 5% they are expressing, even those patients are ABR 0. But after we modified the protocol, look the magic that's happened. It's now 25 to 60% level at around 14 to 30 months follow-up. And they are stable and steady. So today in the world, actually there isn't any other factor VIII gene therapy that is maintaining this kind of level steady. So we have a lot of challenge pre-gene therapy. In AAV, there is no pre-gene therapy challenge because you just infuse in the outpatient almost you can, and gene therapy is over. But in AAV, what I didn't discuss, and I think Dr. Blackley mentioned a little bit, the post-transplant transaminitis and the steroid and immunosuppression for weeks and months in a science that we don't understand and is so empirical is a very big challenge in the world. As opposed to this, where there is a huge challenge in the beginning, but post-transplant, I can tell you, after 2-3 weeks when you discharge them, there's just nothing to do. They just come and say hello to you and just look at the rising factor rate levels, if they're lucky. So far, all of them have been lucky. Whether they continue like this, I don't know. And we just watch and go home. So anyway, at least the editorial in the New England Journal thought that we had solved all the problems of AAV gene therapy. Now, I don't know whether that will be true when we go forward with more patients, but at least that's what we think. All these people to thank at CMC and Emory and the University of Florida. Amazing support and funding from the Department of Biotechnology, very prolonged and flexible. But talking to patients to counsel them for gene therapy phase 1, first in human is a very different game from counseling them for something else. And if there is interest, we can discuss how we did that. It was a 5-step procedure. So that's the conclusion. I will let you read that. It's an amazing time for hemophilia treatment in the world with all kinds of wonderful products. You heard some of them in the first lecture. I referred to some of them. And I think, even without gene therapy, the lives of these patients are extremely good. So it then comes a little bit of personal choice, pharmacoeconomics, and the fact that you don't want to live with the disease if you can. So in that sense, you could live with ME or one of those mimetics or one of the rebalancing agents giving you factor equivalence of 10, 20 or even 30, 40% as is being claimed by some of the rebalancing agents. Why do you need gene therapy? So we will have choices, we will have dilemmas to decide what is the best treatment if all these options become available, as some of them already are. And but even then, it will be a shared decision making, as we use the jargon, at least in the West. It's always shared decision making, but it will be a difficult choice. So let me stop there. I've probably gone a few minutes about my time. Thank you.
Thank you, sir. It was amazing and unbelievable developments. Sir, and we wait for more trials and more success stories. So the session is open for discussion. And what I have, after hearing sir's session, what I feel is like you read 10 articles, you will understand, you'll get a fair understanding of the subject. And you hear sir speaking about the topic, you'll get a concept. You video record it, hear it 10 times, you don't need to read any other article. That's what I feel after hearing sir's talk. So it's open for discussion.
Thank you. I think there's a question at the back. Yeah. You can shout, or maybe somebody will give you a mic.
I think I can shout.
Sure.
Thank you, Dr. Alok. It was a really insightful session. So I'm going to ask a question not from a doctor perspective. I'm not a doctor, but from a patient researcher perspective. So I was listening to how the AAV is built, the transgenes, all that. So recently I was talking to some person from a biosciences company, and they were talking about the use of CRISPR-Cas9.
Oh, yeah.
Yeah. So is that coming into the picture at any point?
Absolutely.
Right,
so there is already a company called Regeneron, and there are a few others that are also following, but Regeneron is already in clinical trial. And they're using a combination of AAV and gene editing. So, and in vivo gene editing. So we have to see what happens. Conceptually is very good. The preclinical data is very exciting. They were actually discussing with us a year and a half ago, and they wanted to also include some of the LMICs, but anyway, for the moment they are not doing it yet. But yeah, it's happening. It's also a technology we must closely watch. Already, for thalassemia and sickle cell disease, the gene editing approach is a registered product.
So is there any specific challenges that happen when it comes to the factor VIII gene, like the complexity or the size of the gene or the size of the protein?
No. So again, this gene editing is only to insert the factor VIII gene. They're not really editing an in vivo gene to make it function. That's not the case in this case. In thalassemia sickle cell disease, they're actually editing one of the transcription factors, BCL11 and A, to make it not function, so that it allows hemoglobin F to rise. But here, it is not a question of editing an existing gene. It is a question of doing editing to insert the gene that the AAV is carrying.
Thank you.
So can I ask a question? Sir, two questions. Sir. One is regarding the rebalancing therapy. So what is the status of regulatory approval?
So all three, Concizumab, Marstacimab and Fitusiran, only in US 2-3 weeks ago, Friday. 2 weeks ago, something like that. So I think they're all approved. Now, the convenience part is there. They have to compete with the market leader, emicizumab, and see who will accept it for what. Already you heard Jan announce, he's not interested. I'm putting words in his mouth. But, he's got people happy on Chakravyuh and emicizumab. For factor 9, he will think about it. But in geographies where that's not the case, we have to think, and we'll discuss during the panel discussion some issues with antibodies versus rebalancing. Rebalancing also, antibody versus non-antibody rebalancing. There are lab-related issues that...
Yeah, that was again the question. How are we going to monitor these patients? How are we going to treat this?
Yeah, so, it's very interesting. I think get into too much detail. But so for concizumab, what's the guidance? You start treatment, 2 months later, you do a concizumab level. And even they're not sure how they have figured out 200 to 4,000, I forget the units, of concizumab in plasma. That's a huge range. If you're anywhere between 200 to 4,000, maybe it's nanogram per ml, something like that, then you're fine. Just continue. There is no other guidance on how to titrate the dose. So I think that's what I said, real world data, it's not zero bleeds like ME in the trial. It is reduced bleeds, 1 to 3. It's good. But in real world, we'll have to see what happens. So that's consistent. Marstacimab, there is so far no specific guidance on monitoring. You give a standard dose, and you see a response that's good enough for the FDA and EMA to say, yeah, marstacimab is approved by EMA as well. It is. And fitusiran, you saw 0 when you were using the higher dose, but they got a little concerned about the thrombosis and transaminitis, so they reduced it. It is still now in the range that is reduced, but the difference in fitusiran is that they are allowing antithrombin level-based titration, so it's not fixed. So you start at 50 for adults, 50 milligram once in 2 months. 4 months later, you're checking the antithrombin. If it's 15 to 35 and the patient is happy in terms of bleed rate, you leave them alone. If the bleed rate is high, you have the option of titrating to 50 milligram once a month, as long as you keep the antithrombin within 15 to 35. Now this is for the regulated markets. We had, as you know, 13 patients on fitusiran, and before the dose modification by antithrombin came, we had all our patients somewhere in the 10 to 20% range, many of them below 12, below 15%, with no transaminitis, no cholecystitis, no thrombosis. These patients were crying when they went into the company initiated hold on the study. Okay, and of course, some of them did well on the 50 milligrams, once in 2 months also, but some of them had more bleeding, and then we had to escalate. So, unlike the other two, here is a physiological hemostatic parameter, a hemostatic protein that you're measuring, antithrombin, and that seems to correlate with hemostasis, and you have the ability to titrate. And because this is not a monoclonal antibody in the plasma, the PT-APTT is not affected. So if you replace factor 8 or 9 in these patients, assays can be done in the lab just like normal. So there are some pros and cons, in the finer aspects of patients. But there's those who are doing well, whether they are on ME or Concizumab or marstacimab or fitusiran, a vast majority will just take the injection and be happy.
And second is regarding the gene therapy. So Jan was saying it could be a mistake to stop researches on gene therapies, and you've just showed us the in vivo therapy shutting down. And so how do you see the ex vivo gene therapy going forward from here?
So it's a tough path for both. For the in vivo AAV, it really is looking a little bleak at the moment unless somebody comes up with a new serotype, a new modified capsid that has much better tropism, Because part of the reason is, we didn't have time to get into those details. When you go beyond 10 to the power 11 vector genomes per kg, you're giving huge amount of these AAV, virus particles, and there's an immune response. At the lower levels, the tropism is not good enough to give enough factor levels. So we need a more effective, efficient AAV vector, and we're not aware of anything on the horizon in that category. So whether the combination of AAV and the gene editing that Regeneron is doing will do better, we don't know. Again, the anti-AAV antibody is a big, challenge, particularly, and somehow these antibody levels are much higher in the LMICs. So in China, South Africa, and India, we have some data. It is so high, so that's going to be a challenge. On the ex vivo, it looks very promising, but there is a big challenge of first the mindset on the patients and the healthcare providers to accept a transplant for hemophilia. So unless we have more data showing that, okay, it is not so difficult as it may appear, it's a problem. And then the technology is very personalized product manufacturing. So just like CAR T cells, but CAR T cells, we have other options. Here, there is no off-the-shelf option, while AAV is an off-the-shelf option. So it will be an option. We will have to see how to make the manufacturing more efficient and easily available. We are working on that, by the way. So we are trying to manufacture in Indian industry as I speak for the phase 2 trial. We will, create the platforms for doing the transduction and move it to a product. But how, and I tell you, there's already inquiry from many other countries in the world, including some in Western Europe, who want to participate in these studies. So it's not a total no-no, but I think, slowly it has to sink. So we have to see how it goes.
So can I ask one more? This is regarding a patient who has allergy to plasma-derived factor 9. There's a child who started on factor 9, severe factor 9 deficiency, inhibitor negative, started on prophylaxis with plasma-derived factor 9 concentrates. He developed, the first episode he developed urticaria. In the second time, he developed hypoxia needing oxygen. So next best option would be an EHL or consistent.
So I don't know whether EHL will not cause reaction. I mean, you may want to try that, but I would think very high chance that it will cause reaction. And I've never felt more helpless and stupid when people write and say they have a child, small child with factor 9 inhibitor who's having terrible allergic reactions with any kind of factor product. So that's where the concizumab and drugs like that, whichever is available to you, concizumab, marstacimab, fitusiran, whichever, that's really magic. So that's one, the way when emicizumab got first registered for inhibitors with hemophilia, it was truly magic because there was just nothing that the bypass agents were doing that would compare with this. So here, this is the one indication where everybody is willing to approve tomorrow and accept the, even the physicians. But till we have one of those, we're really stuck. I mean, you could try one of the long actings under very controlled conditions, but I would think the child will still have some reaction, but worth trying.
Thank you.
And Mike, please.
It was a very precise and informative talk. I would like to ask you a question regarding EHL factor 9 in surgical patients because we haven't started so far. Is it that less frequent as per recommendation?
It's amazing actually because they gave us a kind of donation just to try out 1 or 2 surgeries, and it really maintains surgical hemostasis at the levels we are happy with. We are not targeting 80-100% for 7 days. It's not been our philosophy. So one dose and up to about 7 days it covers well. So depending on the type of surgery you're doing, 1 or 2 doses, many of these products, whichever it is, because they all have very excellent half-life, and if you push it up to about 100-120% for the surgery, it really covers quite well for the first 7 days easily, maybe even beyond that, because we draw for most surgeries after 7 days anywhere in the 20-30% level, we are comfortable with. So it could be a one-dose hemostasis for surgery unless they bleed so much on the table that you wash out half the drug in the blood loss. As long as the blood loss is not so much that you haven't washed out half the drug, from the body, it should work.
Sorry, how many percentage of prevalence increase when they
Sorry, just repeat that, please.
how many percentage of prevalence increase?
How much is it? So you saw, in the AAV gene therapies, in the first 3 to 6 months, 12 months, it's going normal and above. So 50 to 200%. Unfortunately, in factor VIII, every year there's almost a 50% drop, you can see. So that at the end of 4 or 5 years, it's somewhere in the 5 to 20% range. And some of them are going below 5%, requiring prophylaxis. So that's why the enthusiasm in the community is not so high. In the only 5 patients of Lenti, in the initial manufacturing protocol, it was very low, 2 to 5%. But in the lifestyle of those patients with significant joint disease, it is keeping them bleed free. But it's not something we want to accept. The other 3 who got the modified manufacturing, they got 25 to 60%, now stable for almost 9 to 30 months, as I said. So, 15 to 33 months. Okay. So, that will be acceptable anywhere in the world as a successful treatment. So it depends, we don't know. I think, it will depend. What if a gene therapy is giving 10 or 15%? Will some regulator accept it? I think they will. As long as it's otherwise safe and effective and predictable. The unpredictability is the part that AAV is really suffering from at the moment. Plus, the post-gene therapy transaminitis, that is 60-70% of patients requiring immunosuppression, where there is no guidance. We went and wrote up a guidance that will get published soon, but that guidance is total expert opinion with so little evidence of what is being recommended. Okay, that's it.
Any further related to sickle cell gene any trials?
Absolutely. I can talk to you later. This is the Hemophilia Forum, but we've developed not one but 5 or 6 technologies. There is some administrative nuisance that has prevented it from coming to clinic, but it will come. It will come for sure.
Because there are mortalities.
Absolutely.
Good evening, sir. Myself, Sangeeta Chakravyuh, von Willebrand patient. Sir, is there any positive innovations coming for bleeding disorders in women in gene therapy?
So, we're going to have a major discussion. So, women, bleeding disorders in women are no different from the bleeding disorders in men. They are just more symptomatic and some are more common probably in women. The commonest one will be von Willebrand. As Dr. Blackney said, the factor mimetics may be a very good option. They have not been evaluated enough. So, emicizumab and similar drugs, people are already beginning to evaluate them, so that could be a very good option. Unfortunately, the recombinant factor VIII extended half-life will not be useful. So the first important thing is, maybe I should answer you differently. You asked women with bleeding disorders what's being done. So first thing is to recognize that not all menorrhagia is just local cause. It could be an underlying blood disease. So evaluating them, and I think you already made a policy, Dr. Rahul mentioned that, so we're going to discuss that. Evaluating them carefully is a challenge because no hemostasis lab in the world has the ability to evaluate all those rare bleeding disorders easily. So we have some options of strategies on how to do that, getting to a specific diagnosis. Now what are the commonest you will come across in India? The top 2 will be von Willebrand and Glanzmann in South India. So then we need therapies for von Willebrand and Glanzmann. Glanzmann gene therapy is possible. People, we're trying to work on that. But in von Willebrand, gene therapy is possible. In fact, there is some discussion about it, but it's not going to be easy. But there are many other options. for vulnerable and including the factor VIII mimetics.
I'm asking to improve the quality of life of
Absolutely, absolutely. But immediately, I mean, there are plasma-derived products that you should demand that should be made available to you for at least frequent episodic, if not prophylaxis, depending on the bleeding profile. But menorrhagia alone can be managed very well even without factors, with hormones and tranexamic acid, as long as the gynecologist and the hematologist are familiar with what to do.
So the problem is like hormone treatment cannot be done for a prolonged period, so which causes later problems.
We can discuss that tomorrow or whenever the discussion is.
Thank you so much. Thank you.
If there are no more questions, we will wind up this session. Thank you, sir, for that very informative talk. And today we are lucky and we are blessed to hear from these two giants, and hope the insights gained from these two talks help us formulate better policies for the future. Thank you. Thank you to our wonderful speakers and our chairpersons for the evening. Now we move on to one of the most crucial conversations of the evening. We now present a panel discussion that brings together expertise, experience and vision. Moderating this session is Dr. Neeraj Siddharthan, Head of Clinical Hematology and Stem Cell Transplant at Amrita Hospital. We are honored to have a distinguished set of panelists with us. I'd like to invite them on stage. Dr. Vijay Kumar, Medical Officer and in charge at Alua HTC. Dr. Rahul UR, State Nodal Officer for Child Health and Rare Diseases for NHM Kerala. Dr. Srinath S, Professor and Head, Department of Medicine, Medical College Idukki. Dr. Dev Kumar, Professor and Head, Department of Pediatrics, Government Medical College Koni. Dr. Sheila T.A., a leading pediatrician at Government Medical College Kalmasheri. Dr. Riaz, State President, Indian Academy of Pediatrics. And Dr. Lata, District Nodal Officer, Kannur. I welcome all the panelists on stage.
Welcome to all the esteemed panelists. I would also request Professor Alok sir and Professor Jan Dagny to be a panelist. Some of the questions will be directed to you, of course. We need your help in solving some of the issues. Okay. So this is. So we after those brainstorming lectures, we come back to what we face in Kerala, and then let's try to see how we can utilize our new knowledge to solve the existing problems. So, okay, we have time constraints, but we should still discuss. So, I've got about 15 questions, maybe 1 to 3 minutes per questions. We can go quickly. So I'll start. So Ashadhara scheme is what what has happened after the Chakravyuh 1. So I would start with Vijay Kumar sir, to tell us about how hemophilia care in Kerala has changed after the implementation of Ashadhara scheme.
Actually, the care for hemophilia in Kerala started under the Karunya Benevolence Scheme in 2010. Karunya Benevolence Scheme was under the Lotteries Department. In 2000, during 2010, 2011, 2013, the treatment was limited to 2 lakhs per annum per person, and that ceiling was there, and no prophylaxis was included in that. In 2014, the ceiling was raised to for on-demand therapy. Ceiling was raised to 3 lakhs, and no ceiling for children under 18 years of age. Regular replacement therapy was started for the first time in 2015, March 21st to be exact, in Ernakulam under the auspices of the district panchayat, local administration, for those under 10 years of age. And it continued unabated, and the results were very promising, and proposals were submitted to the government of Kerala for starting pediatric prophylaxis. In 2018, there was a meeting convened by State Blood Cell, wherein the Honorable Minister for Health, Additional Chief Secretary, and Professor Alok Srivastava were present. At that time, Dr. Neeraj and myself represented the hemophilia part, and we had submitted a proposal. Based on the studies at Alua, we asked for actually the low dose prophylaxis, 10 to 15 units per kilogram, then twice weekly. And that time, Professor Alok said that's not possible. At least you should have an intermediate dose prophylaxis, and that was accepted because the Additional Chief Secretary as well as the Minister, Additional Chief Secretary also said that it should be at least an internationally accepted prophylaxis, not something you have done there and reduce the bleeding rate from 40 to 4 or 5. So it should be less than 3. So that was accepted at that time in 2018. But actual prophylaxis for under 18 started in 2021 because of the natural calamities at that time, the government could not take it up. And once the Ashadara came, it was a great blessing for the hemophilia community. So they came under the Health Department, and National Health Mission took it up and introduced the pediatric prophylaxis for under 18, factory prophylaxis to start with, and now during the last from 2024, it is emicizumab low dose prophylaxis for all under 18 years of age, universal prophylaxis. So that is proved to be a miraculous drug for the patients with substantial reduction in annual bleeding.
Thank you, sir, for that perspective and taking us through that. Sheila, madam, your perspective on how Ashadara has changed the treatment.
Actually, as sir has mentioned, the NHM blood cell was formed in 2020, and after that, the Ashadara program was implemented in September 2020. So we were having so many patients, inhibitor status around 25 to 30%. So we were eagerly waiting to start the prophylaxis, and the prophylaxis first in government setup was started there at Alua, and I had received all the encouragement from CMC value training only, as Sida has pointed out. Alok sir only responsible for all this, is time management and all, and sir was my guru to start prophylaxis for 4 children under 10 years of age with severe hemophilia. And we had started guidelines. We have released guidelines for prophylaxis in 2020, and 21 itself prophylaxis was started under 10 years of age, and emicizumab prophylaxis was started in September 21 for under 10 years children. 11 children were selected. That was just depending upon the severity. We had selected patients for emicizumab, And later we have added more children, under 10, all children with inhibitors were added. And at the same time we were able to provide prophylaxis with factor 8, factor 9, plasma-derived factors first, followed by recombinant factors, and also FIBA and factor 7 for inhibitor patients. And in 2022, we have formed a scoring system. It is depending upon certain factors. We only have formulated. The State Technical Committee was formed in 2020, and the factors criteria were considered were the ABR, the difficult venous access that should be certified by the treating physician, and the distance, that is the proximity to the treating center, the joint status, and the major bleed. These were the criteria selected, and we could add more patients. About 22 patients were again added depending upon, but there was some subjective variation in that scoring system. So we have again formulated a protocol. Then these major criteria were split up. Again, just like treating physicians, along with the MRI documentation, MRI USG or whatever it is available, and this bleed should be certified. History is not enough. That is how again we could add more patients for emicizumab, and we had analyzed the cost effectiveness, and for about 1 year we have compared for 7 to 10 patients first, and it was just 1/3 of the cost incurred while using FIBA and factor 7 for inhibitor patients. So bleed were very less. The major advantages were limitation of activity was improved well, the reduction in the pain, reduction in the school absenteeism, and the joint reversal of all the joint involvement, target joints resolution. So we had planned to add more patients, and we have started on recombinant patients, recombinant factors for the other children also, all under 18 children. So they were doing well than the plasma-derived factors because the needle was very fine. The pain, there was reduction in the pain after using recombinant factors. But again, more and more requests were coming for emicizumab too. So depending upon that, we have again added more patients. And one crippled adult patient was also selected for emicizumab treatment during 23. And in 24, we could extend for more patients, more number of patients up to 18 years, considering the age of musculoskeletal development and the cost effectiveness also. So we had added more patients, and along with that, a few patients who are inhibitor positive were also selected. That was, we had discussed online technical committee meeting several times, and case-to-case based discussions were made. Sometimes it goes to 2 to 3 hours. We had all technical committee members had to sit and select these patients. That is how there were no complaints at all regarding the selection of patients. And in 25, we could add 2 or 3 patients who are inhibitor negative, adult patients also. So now we are hoping to add more, extend this age up to 25 years if we can. And the other patients are doing well with an extended half-life factor also we are planning to use. That's how why I asked that question, sir.
Thank you, madam, for that elaborate perspective. And Dr. Srinath sir, do you have anything to add?
I don't add much because it's Asatara is a comprehensive treatment program started by the government of Kerala, and before that there was no, it was not streamlined. After the Asatara, the treatment, the prophylaxis, number of patients, everything was streamlined. That was the great advantage of the Asatara program because it uses a digital platform with the use of the mobile app. We are entering the patient's name, the dosage, everything into the portal system, so that we can note that how much factor needed, how much the procurement is became very easy, and everything became, the number of patients, everything became very easy following the Asatara program.
So it is more like what Dr. Jan Blatney mentioned, personalized, because you are taking step by step. Every patient is being discussed and then
And the second thing is that it includes the training programs also. So everything after the Asatara, it means everything is streamlined.
So next question is to Dr. Rahul. Dr. Sheila mentioned about the technical committee meeting. So can you please tell us, the audience, about how this technical committee was formed and how impactful it has been and on the current.
So most of the points have already been discussed in the previous question by the speakers. So technical committee is basically the backbone of the entire program. So as mentioned by all three of them are actually members of the technical committee. So prior to the introduction of this Asadara program, there is a technical committee from the beginning of this program. So prior to that, the treatment was not uniform. It was like scattered, like Alva had prophylaxis earlier, so that benefit used to get for people from Ernakulam district only because it was a district panchayat program. But when it is expanded across the state, the advantage of experience and expertise from all the medical college faculty would be incorporated into a single body. And again, as Dr. Srinath had mentioned, we had an opportunity to discuss cases one by one and provide a personalized care plan for each patient. Like Dr. Sheila had mentioned, we not just implemented some prophylactic program for less than 18 children. That is a policy. Apart from that, in inhibitor cases, adults and non-inhibitor cases, we have adopted selected cohorts or individual patients based on the discussion in the technical committee. So it is more like a personalized care being provided based on an informed decision-making method after discussing in a technical committee. So that is the major component of the entire program. And also the district level nodal officers and treating doctors in the periphery, they also get an opportunity to come up with their cases and present it and get a clinical solution for such cases. It is not just about making a decision of what medicine to give or whether to be converted into emphysema prophylaxis, etc. But they get an opportunity to make a decision in difficult clinical scenarios. So last day when I had an opportunity to discuss with another state officials who are handling hemophilia care, their major question was, how can we implement this program without hematologists or trained persons in hematology in a state? So this is an answer for that question. Because when a district nodal officer, who happens to be a physician or a pediatrician, they get an opportunity to discuss their case in the technical committee and find a solution, not just to decide whether the patient requires prophylaxis or not, but to how to manage in a minor bleeding condition, a surgical condition, or whatever it is. That is an answer for that question also. So this is a model of how, in a resource constrained setting where we do not have much hematologists or practicing hematologists in the state, we can utilize this kind of hub and spoke method with the technical expertise and the discussion that happens every month. So technical committee is the core component of the entire program.
Thank you, Dr. So this question I think Madam has already answered, and I think Dr. Alok sir has also briefly mentioned about that, the emicizumab prophylaxis, when we celebrate emicizumab prophylaxis for factor 8, don't forget factor 9. So that point apart, sir, do you have any other comment on this?
So, are we coming back to this again, Neeraj? There was a question where you wanted comments on emicizumab in Kerala. Is that now or is it later?
No.
It's now.
No.
Okay. So I tell you what, I don't think there are words enough to describe what you have achieved. Okay, it's absolutely amazing. And the impact that it is bound to have on patients and the physicians who are managing them will be tremendous. So when we do something good, more is expected from you. That's the problem in life. Expected in many ways. I'll tell you why. Number one, it is not insignificant expense, and everybody wants to know what is the return on investment in terms of outcome. So what are you doing? Document the improvement in a systematic way. That's very critical. It is also critical from not being subject to criticism internationally because you are using half the dose, 3 milligram once a month. It is a no-brainer. We have written some articles internationally. In my mind, it's a no-brainer that it will work. And already the early data from the randomized control trial going on at KEM Mumbai, I was speaking to Dr. Chandrakala. She's talking in June in the ISTH meeting. It is showing excellent results. But unless you document the outcome, people will say, yeah, they did something in Kerala, we don't know what happened. So you have to document the outcome and report it. That's number one. Second is, between policy and implementation in every government there's a gap. So how many people are really receiving it in the expected way also needs to be documented of the documented PWH. Now, in most states in India, the documented numbers are, I don't know, anywhere between 10 and 50, 60% of the expected. I am often not sure what that number, the ratio is, but the other thing you want to do now, because you are able to offer treatment to very young children, because emicizumab in the West now, some people are starting within weeks of birth, and Dr. Blackney can expand on this, mainly to prevent intracranial bleeding. So in some series, intracranial bleeding varies from 2 to 8% of children with hemophilia. So now, the people we didn't detect all these years, did they lose life so early that they never came to detection? So how do we increase that diagnostic rate in the community so that you reach close to 100% of the people born with hemophilia in Kerala and offer them early intervention?
Thank you, sir. Okay, so again, this is a question regarding home therapy. So, telling about the delays and deaths in taking treatment. So, not everybody is on emicizumab. The children are on emicizumab, of course, but adults, not everybody is on emicizumab. So, how important is home therapy from your experience, and what are the steps that a state like Kerala can now take to implement home therapy?
Thanks, Albert. I'm definitely not getting in a position to give you any advice since we're doing the workshop anyway, but I just can share with you some thoughts. Well, for those who are on emicizumab, especially if the country has limited resources, this is to me not the first line target. So if you are on emicizumab, you may not necessarily need the home treatment as the first step. But what is the problem are those who are on factor treatment, and specifically because I understand that there is still a significant number of people who are on demand treatment. And if you are enabling the home treatment, you save joints, you save lives, and you save money. That's quite important thing. Because the sooner you start a treatment, the less it costs, and the more efficacious it is, obviously. What we did is that we implemented this 20 years ago in a very similar manner. So we started with the factor treatment for those who were on demand, and then once the prophylaxis came with the factor, obviously it has to be done in the home settings. The only issue is that once you want to implement home treatment, you have to be able to administer the medication. So there would be no reason to have the vial at home if nobody is able to inject it. Either the child or the person or the caregiver or somebody who is available 24/7, like the GP or whoever, that may be different in a different setting. So my suggestion would be to start with those who are dependent on the factor treatment, to enable them to have the home treatment because it helps a lot and it saves money. Second, once you are there, and then you can suggest also the possibility of home treatment or having, because emicizumab is given at home anyway, so that's not the problem, but having the treatment for the breakthrough bleeds. But again, for this you have to be sure that the skills are there. And that is one of the tiny disadvantages of emicizumab treatment, that even for our patients who are having the good skills with the factor treatment, once they switch to emicizumab, they lose it. Because they never need it, basically. If you don't bleed for 3 years, you can hardly forget how to inject yourself. But that's something which is not an issue now.
At your country, do you have a systematic training implemented for venous access for the caregivers?
Yeah, there is a scheme when the hemophilia nurses are treating, teaching all the parents to use it. If this is somebody who would start the secondary or tertiary prophylaxis in adulthood, then this course would be given to the person as well. And there are home nurses who are able to administer factor in case that the person or the caregiver is not able to do it, which is paid through the insurance companies.
Have you found any challenges with respect to, when you allow that? Is that one of the concerns earlier discussed, in the earlier forums were, some challenges of drugs being misused?
That's a very important thing. So, for example, in my country, it is a legal request. So, if you can be provided the home treatment for a certain limited time. In our case, it's for 3 months. I shall not provide anybody with any medication for longer than 3 months. I do it. I give the very precise record what was given, and before the patient comes back for another prophylaxis, it has to be very precisely documented. So I put this lot of this factor of that dose for that reason at that day on that hour. And this is what the patients do, and now you can do it also with the applications. That's plenty of applications which are available, also non-commercial. For example, the WAPS Hemo as well can do it. And you can use it, and you very well document it, and that's the feedback for the insurance company. So I pay the money for it, but I get the very precise record for the audit, how it was used, if it was used meaningfully, and so on.
Thanks. So, before I go to the next question, let me ask a question to Dr. Riaz, who is representing IAP. Dr. Riaz, thanks for coming. And then the question is, what would you foresee as the role of an organization like IAP with grassroots all over the state in a care of a rare disease like hemophilia?
Thank you for the opportunity. So, as it was told, Indian Academy of Pediatrics is one of those professional organizations where its activities are not limited to members. So we do a lot of awareness programs in the society, and also we join hands with the government in providing these facilities. In Kerala, we have many examples. One of this is Ashadara. Then we have the Mitai program for type 1 diabetes children. We have the care program for other rare diseases. So in all these aspects, Indian Academy of Pediatrics conducts training awareness program for pediatricians as well as for patients. And we support all the activities of these programs. And on the Hemophilia Day, in connection with the Hemophilia Day, actually the monthly newsletter of IAP Kerala chapter has an article on the management by our Devuma sir, which is actually given to all the members. And also on Monday we are conducting a webinar where Dr. Rahul is going to discuss with all the pediatricians in the state about the Asha therapy. So this is an ongoing happening which is there all through the year. And I think especially in cases of early depression, like we were discussing about babies or children who lose life during circumcision. So that again, there is such a possibility. Like type 1 diabetes is an area that I work on. So I know now very few children come to our ICUs in a state of diabetic ketoacidosis because of the awareness. So that is one area where the Indian Academy of Pediatrics is working. So we will continue this work and we will support all the programs.
Thank you very much, Dr. Riaz. So this question for so this question is, I would give it, this is for actually if Dr. Devkumar sir can, this is not for the Kerala as such. What I mean is that the 24/7 availability of clotting factor concentrates at your center for all the patients that you cater to. Is that a challenge, or
Yes, it's a challenge. But I think what is most important is documentation. document all the details regarding the factor therapy in the previous year. The sisters are given instructions to document it in the way itself. Wherever it is given, it is well documented. And then you take an annual indent of the previous year and give recommendation to the authorities how much you have spent or how much factor you have to get.
So it is like how much percentage for the next year you would request?
Yes.
So it's
depending on the previous year's use, you can give an indent.
Increment by 10, 20%? 10%.
Yes.
10%.
10%.
Okay, thank you. Yeah, please.
Regarding the 24/7 availability, in Kerala, treatment for hemophilia, the factors are available from sub-district hospital levels upwards. So sub-district level, district level, and medical colleges in the public sector. So apart from this, addressing a few concerns that were discussed earlier, like we also provide, we have done a geographical mapping of our patients across the state. So wherever we have patients who are either bedridden or geographically marginalized or belong to any particular community which is marginalized, we have a plan to expand this treatment to the community health centers wherever it is available. So the advantage of this is that, so the things that we look into is that we need proper storage facility at these centers. We need 24/7 medical attention feasible at these centers, so that if any on-demand conditions occur, they need to get the medical attention rather than being nothing. But the challenge related to this is that the availability of factors that the shortage that we are facing at present. So from the 96 centers, nearly up to 100 centers, including the newer CHCs that has been added. From that, we, according to the supply, we get to reduce it to regional decentralization or centralization. That is a challenge for the last quarter. But apart from that, the 24/7 availability we ensure like this. Up to the taluka level hospitals and beyond that to the CHCs as per the need be, and maybe later on with other questions, other aspects that have been covered will also be discussed.
Also, these drugs are included in the essential drug list, so it is available in all the casualties, at least in medical colleges, as they come in the essential drug list.
Thank you. I have a question. Again, this is regarding a patient in the remote area. So Dr. Lata is here. So this question I would like to refer to you, Dr. Lata.
Thank you for this opportunity. I'm a nodal officer in Kannur district, which is one of the among the northern districts in Kerala. Remote areas could be in the sense that it is geographically a remote area, or the patient is not able to come to the designated center as patient is bedridden, or it could be any of these. So what like Dr. Rahul has already told, at the beginning of the program itself, every district is supposed to, we all have a technical committee at the district level, where at the DMO level, that is district medical officer level, we have a deputy DMO who is in charge of this program. Then we have the district nodal officer, the nurse coordinators, and the district program manager. So a mapping of all the hemophilia patients in each district has begun, as Dr. Rahul has told. So based on the mapping, where areas where we have more patients, so that hospitals where the 24/7 that is medical care can be given. So the treatment has been decentralized to those centers. Another is we have Wayanad district and Idukki district where it's the remote areas. So in Kerala we have a very good palliative care program. So the palliative care program has been built. In my district itself we had a hemophilia patient who had a spinal bleed and was bedridden. So at the primary health center the palliative care is integrated. So we contacted the medical officer. So the palliative nurse agreed, and that is nurse was sent to that patient's home, and that's what we were giving factor. So similarly, even at the community health center level, we have where if it's 24/7 medical facility can be given, we are decentralizing.
Are we utilizing telemedical facility, or is it planned to be used? Because there was during COVID time, I believe there was a telemedical consultation. Sanjeev.
Yes, during COVID seasons we used to conduct e-health services. Now it is not. Now
can it be explored in the remote areas?
That can be utilized, like as Dr. Leda had mentioned, when a nurse can go to the home and provide treatment. As I mentioned earlier, how the technical committee acts. This telemedicine facility can be used for consultation and prompt response can be given to the patient at that site itself. So that can be used, but in the clinical setup and scenario in the state, it was more helpful during COVID times, but this can be explored and utilized further.
So I mean, very interesting to me. Our stroke medicine is managing stroke thrombolysis in Meghalaya from our telemedicine unit. I'm just I was just curious whether we can explore, because when we conducted a camp in Idiki before Sir you came, we realized a lot of people are not reaching the hospitals because of the geography of the region. They just can't reach the hospitals. So,
the most important component is the nurse coordinators, as Dr. Leda has mentioned, because they used to enter all these details in the Ashadara ID, and they used to conduct, we used to conduct various training programs, of which all these BPM, NHM, all those participants. And previously we were not having any buffer stocks, but now at all centers we are having buffer stocks. So at night also, Karunya Center will be open up to 5 p.m. or 6 p.m. So we are finding it very difficult to acquire these factors, especially FIBA factor 7 like that. Dr. Neeraj will be remembering one patient, 19-year-old with crush injury and had all these factors. FIBA was not available at that time, and compartment syndrome occurred. And we could give factor 7 on the next day of morning only and refer. They were not willing to go also because of the non-bystander. So such problems, so many problems occurred. But after this implementation of Ashadara program, everything made easy. And especially as essential drug list it is available, and store superintendent is in charge of all these. So there is responsibility. We used to provide utilization certificate and 1 dose to these patients. After giving 1 injection as on-demand treatment, 1 dose will be sent with the patient also.
So we have completed 1 round. I think grossly overshot time. So we have more questions, but then there is also 1 more session following this, right? So, yeah. So I think we can probably continue the discussion tomorrow. I think because it will never end. So, thank you everybody for the fantastic discussion. Please take that, sir. We'll have a photo with.
session. It is with great pleasure I invite on stage Dr. Neeraj Siddharthan, who is my teacher and mentor, an inspiring teacher and astute clinician. So you've been instrumental in driving hemophilia in the state of Kerala. He will be talking on innovations in hemophilia management driven by unmet needs. Welcome on the stage, sir.
Not a good feeling to stand between the dinner and so I try to. Most of my the topic. This is a sponsored session, so most of the topics have been covered. But the title is interesting. Innovations driven by unmet needs. So as Alok sir was mentioning, as more and more innovations have happened, you have more and more expectations. So now unmet needs are slightly different now. Okay, so we need, in addition to bleed protection, we need a better joint health, and you don't accept physical burdens, and we need a better quality of life, and then we are also worried with burden of administration, the venous access, going to hospitals, lack of availability of home therapy. So these are some of these unmet needs even in this era. So with regards to the bleed protection, usually people with prophylaxis are protected, but some of them are still insufficiently protected. And as has been mentioned earlier in the two talks, some of the non-factor therapies also patients will experience bleeds. And more so in patients with inhibitors, and those with inhibitors generally are known to experience a greater burden of bleeding than those without the inhibitors. All of them are not yet reached the zero bleed state. There are some whom we should still tackle. Then it's about the joint health. Okay, so patients already have joint impairment, pain, arthropathy, and some of them have the need for surgery, irrespective of the fact that they get the best possible treatment. So we know about target joints, 3 or more spontaneous bleeds in a 6 months period, and a lot of people who are still on prophylaxis still have target joint bleeds, and many of the patients in the adults in the state still suffer from target joints because they are not on prophylaxis. This we briefly mentioned in the first talk about the physical burden and poor physical functioning, the limitations in the daily activity, the recreational activities. Dr. Jan Bladner was mentioning about the green, yellow, and the red. The level of activities, and we know that the physical activity remains lower in people with hemophilia than the general population, and the reasons remain different in adults and pediatrics, and of course in pediatrics we see there are a fair amount of restriction from the parents because of the concerns of bleed. Then comes the quality of life impairment. So a lot of literature and studies have been there on the emotional, physical and psychological and social burden of the disease, and we know those physicians treating the patients that we have to deal with increased mood swings in our patients, including depression, anxiety, anger, etc. So, and this is generally much higher compared to the general population. And likewise, what happens in the bleed, the development of inhibitors is also associated with a dramatic decline in health-related quality of life. So, the other question is on the burden of preparation and administration. So we have the standard half-life and extended half-life product, which will still need an ID access and going to the hospital. Even emicizumab now we are administering in the hospital, so again, even with the newer therapies, these issues are not completely resolved. We briefly mentioned about the home therapy that Jan was detailing on that. So of course that is a barrier that we have now. We don't have home therapy in the state now, so obviously there is a scope for improvement and needing to address that. Hopefully by the time we come back to Chakravyuh 3, we should have started home therapy. So of course there are a lot of barriers to home therapy, and which includes storage concerns, injection techniques, lack of awareness, and policy inertia. Most of which I think we got insights from Dr. Blackney and the way forward. So the way forward, of course, can be through innovations. Innovations can be two ways. One is newer drugs and newer modes of drug delivery. And so again, Alok sir has already taken us through the newer drugs, especially the concept of rebalancing. And so these slides are essentially repetition. So I think in the interest of time, please allow me to skip these. And of course, the FPA also we have dealt with. Yeah, but I'll talk about factor 8 mimetic. So this is interesting because further innovations are happening in factor 8 mimetics. Alok sir had briefly mentioned about it. So it's about optimization of the process of engineering, which changes the structure of a therapeutic antibody with the purpose of enhancing the safety, efficacy, and developability. So there are three aspects where we can innovate in the structural changes to the binding of an antibody. One is where it binds, the epitope binding, and then the cofactor activity and how strongly it binds. So I think research has been ongoing on the bispecific antibodies that and which has the potential for the optimal factor 8 mimetics that can more easily mimic the function of the factor 8. So essentially we have the cofactor activity and the affinity. We can see that the optimal affinity zone is a low affinity. If it is too low, there is a risk of inefficient complex formation. If it is too high, there will be a non-specific binding. So that's the zone of optimal affinity. And then you have a zone of optimal cofactor activity. Again, if it is too low, there is inadequate hemostasis, and if it is too high, there is excessive hemostasis. Okay, so the factor mimetics should be ideally optimized to have a low binding affinity to factor 9A and then deliver a powerful cofactor activity. And that is the anti-factor 10A arm. And then there is an anti-factor 10 arm, which is the bispecific, the second arm of the bispecific. It is optimized to have a low binding affinity to factor 10. So that is the ideal mimetic with a low binding affinity and a high cofactor activity. Okay, that is about the factor 8 mimetic. And then regarding the newer drug delivery, this is essentially with respect to the home therapy and the challenges associated with it. So again, Alok sir was mentioning about the pen, that is being used for the concizumab, and it's again the patient. Dr. Riaz was mentioning about the type 1 diabetes. The type 1 diabetes is being managed by pens, which the patient can self-inject, and then of course there has been surveys from the patients and then which looked at how easy it is to inject. So that's again one another way. I think there are now more options when you have a pen and a daily injections. Who knows? Many patients may actually prefer that. So one more option for treatment for us in the for us physicians. Okay, so and of course the learning is learning to inject with pen is much easier and much easier to train. Okay, so I think I have covered both the factor VIII mimetic and the pen, which are the innovations, and of course in this era we are in evolution and revolution, so the treatment goals are constantly changing. By the time I finish this talk, something new would have happened already. I think essentially hemophiliacs are not going to be hemophiliacs anymore, and our goal would be changing to allow them to be like a hemophilia-free person or a normal person. Thank you.
Thank you for the informative session, sir. Now I would like to invite Dr. Vikram Kumar DNT on the stage. He is a State Nodal Officer of the state of Andhra Pradesh. He will be talking on unleashing transformations and strategies to improve prophylaxis in hemophilia.
Very good evening to esteemed faculty, delegates. I would like to thank Amrita Hospitals, NHM Kerala for giving this opportunity. After this, what we have heard, this high-end lectures, I'll be talking more of a basic stuff. In the next 20 minutes, I'll give a brief about hemophilia. Then we will see some clinical scenarios where EHL factors score more superior to the standard half-life factors. So these are disclosures. So this is the annual global survey 2023 data, where we have around 4.6 lakhs of bleeding disorder patients across 152 countries. Among these, more than 50% are hemophilics, and India has around, as per this survey, India has around 26,000 registered cases, which constitute around 8 to 10% of total hemophilic population. So basically, as per this survey, India is the largest country to have hemophilia populations. So still, this is the under diagnosis, because we have many number of cases which are undiagnosed because of lack of awareness and limitations in the screening capabilities. So in spite of being the largest country with the hemophilia populations, who has a country with a large number of hemophilics, our per capita factor utilization is one among the lowest among all countries. So there is a wide gap between the number of patients and also the treatment availability. So, this gap especially now we are seeing the central government is showing more interest, started showing interest, especially for the hemoglobinopathies, where the sickle cell elimination program has come. But so far, no national policy has come for this hemophilia and other rare genetic disorders. So hemophilia, as everyone knows, it's a rare genetic disorder where there is a deficiency of factor VIII in hemophilia A and factor IX in hemophilia B. Always compare hemophilia with other diseases which has protein deficiency, like hypothyroidism, where you have a deficiency of thyroxine. So you supplement thyroxine and you monitor the TSH level. Similarly, like type 1 diabetes, you have an insulin deficiency, you give insulin. So similarly, or in both the cases, you give thyroxine or insulin regular basis. You don't wait anything bad to happen, then you start supplementation. So similarly, in hemophilia also, there is a lack of factor VIII or factor IX, so you have to replace the missing factor. So that is the treatment for the hemophilia A. So what if you don't replace the missing factors, especially this in severe hemophilic patients? they will bleed spontaneously, more commonly into the joints, and over a period of times, this recurrent joint bleed will deteriorate the joint health, and over a period of time will develop hemophilic arthropathy and subsequently results in a disability and poor quality of life. So prophylaxis or replacement therapy is the standard of care for any severe hemophilia patient. So are we doing this prophylaxis? So this is data from the 2020 annual global survey, where less than 10% of Indian pediatric patients with hemophilia are receiving the prophylaxis. For adults, the numbers are much lower. There is no mention of prophylaxis data in 2023, but as the awareness is increased, the numbers are increasing, but there is still a lot of scope. So, as I said earlier, if you don't if you don't prevent the spontaneous joint bleeds, eventually it will turn into a disability and poor quality of life and complete dependency. So most of our Indian patients are taking the on-demand therapy. That means where they are taking the factors only when there is a bleed. So this can give a temporary relief in terms of reducing in the pain and swelling, but it will not alter the natural course of disease. So the patient will still have a bad joint disease and disability over a period of time. So prophylaxis is the standard of care. So patients who are on prophylaxis will have less bleeds per year. This was even proven in multiple landmark clinical trials where they have shown that prophylaxis results in less joint bleeds, better joint health, and better quality of life. So what preventing us from implementing the prophylaxis? There are multiple reasons. There is a affordability, cost issues, availability. We are not going to talk all these things, but we will talk about the treatment factor-related, clotting factor-related, treatment-related factors which are impairing the wide implementation of prophylaxis therapy. So let's take the first clinical scenario where we have a 12-year-old child is a severe hemophilic diagnosed at the age of 8 years. He's a severe bleeding phenotype who bleeds around 2 to 3 times per month, and he has both knees as target joints and his inhibitors negative. So he needs factor VIII infusion every other week, and he has to travel 3 hours for the factor infusion. Because of this, he stopped schooling at the age of 7th standard. So this patient was taken for the prophylaxis, high dose prophylaxis, where he was given standard of life factor concentrates targeting around 30 to 40% correction twice a week. In spite of that, he was continues to bleed, and then it was changed to the thrice a week. That means every other day he is getting factors. With this, he has shown some improvement, but because more frequent administration, he has shown poor compliance to the treatment. So what we can do for this kind of patients? So hemophilia is a heterogeneous disease. You might have seen in your clinical practice also, some patients even with the factor level less than 1% will not have any bleed. And some patients with severe hemophilia, they respond very well even if you give once a week factor. And some patients, like in this case, even after giving alternate factor administration also, they continue to bleed. So each patient is different. So patients like this who needs who are on high dose prophylaxis, giving factor every other day, the venous access, it is not only the venous access, it is also the compliance will be affected. So coming and every other day and getting prick and factor administration is a very difficult thing. So these patients will get benefited from the EHL factor. So this patient would have started on extended of life factor 50 IU per kg. That will once if you start once in every 4 days, then subsequently change to once in every 7 days. So this will increase his adherence to the treatment prophylaxis, and that once the patient is compliant to the treatment, eventually there will be decrease in the joint bleeds, and the target joint resolution will start, and it will eventually improve his quality of life. So so if the same patient continues to be on EHL factors, there is a high chance that after some years he will be having zero bleeding rate. So what EHL has done, which is superior to the SHL, standard of life factors. The advantage with the EHL factor is the frequency of administration is much less. So when the frequency of administration is there, the compliance will automatically improve. We might think that what will happen if we can decrease one dose per week, so that eventually will translate into 52 doses per year. So this might not be a big issue for us, but it will be a very important thing that matters to the children, especially with poorer venous access and their parents. So less frequency of administration, better compliance to the treatment, but reduced school absenteeism, reduced work absenteeism. So all these are advantage of less frequent administration. And one more thing, one important advantage of EHL factors is because of their long half-life, they have higher trough levels. Because of higher trough levels, there is not only decrease in the clinical bleeds, but also in the subclinical bleeds. So that will encourage the child to participate in the other recreational activities. So eventually both these things will help in improving the quality of life. So, and this is very much more relevant for the factor 9 patients, because factor 9, the half-life is increased with EHL almost 5 times more. So the overall reduction of factor infusions will be more than 60%. So there is multiple trials from the Indian setting also where they have used much less EHL factor dose than what prescribed in the drug insert sheet. So still they have showed a very good outcomes among the hemophilia patients. So coming to the second scenario, if the patient of 22-year-old who is around weighing around 50 kg, who is on-demand therapy, inhibitor negative, again with severe bleeding phenotype, multiple target joint, now is planned for the total hip replacement surgery. As you all know that the challenge with the hemophilic patients who is planned for any invasive procedure is the intra and post-operative bleeding. So these patients require pre and post-operative factor infusions to definitely maintain certain trough levels. So EHL factors, because of their higher trough levels, provide a better hemostatic control over the SHL factors. So this is, as everyone knows, this is a standard guidelines how we follow pre-operative and post-operative, what factor levels to be achieved for the normal SHL factors. So this patient was taken up for surgery with EHL factors, where we have given 50 IU per kg on day -1 to day +7. So after that, he was started on normal prophylaxis. So total doses he was requiring is around 9 days of factor administration, and total factor utilization was around 22,500. So with these things, there is a scale how you measure how better you achieve hemostasis. So if the patient achieves a hemostasis like a non-hemophilic patient, you say excellent. If it is within 10 to 25%, you say is good. So he has achieved excellent hemostasis, and there was no uneven pre and perioperative event. There was no major bleeding events in the perioperative period, and there was no excess bleeding or any bleeding. Similarly, with factor 9 also, there is a single dose of, as mentioned, there is a single dose of 80 IU per kg, which you can do many surgeries, and if required, you can give 1 or 2 doses of 40 IU per kg in the next 7 days. So, as I said, EHL factors, because of higher trough levels, they provide a better hemostatic control compared to the SHL factors. The same patient, if you had gone for the standard of life factors, you would have required more doses, more the factor concentrate compared to the EHL factors. Coming to the final scenario, where if the patient has a life-threatening bleeding. So he is a case of severe hemophilia B, who is a 38-year-old male, inhibitors negative, who presented with acute onset holocranial headache and vomitings and episode seizures. Again, this is a classic presentation, and the CT showed an intracranial bleed. So these patients, generally, if you treat with the standard of life factors, you give, you calculate the dose, you give twice a day, then you change to once a day. So for the advantage with the EHL factors is that you give a fixed dose 80 IU per kg, and then you give subsequent doses every second day, another 5 doses. So with this, he was recovered well, and subsequently he was put upon prophylaxis. So same patient, if you would have received the plasma-derived factor 8, you would have required more than 15 doses. Even if you take once a day also, you will be requiring more than 15 doses of standard of life factor concentrates. So with these EHL factors, he required much less dose and much less factor quantity. It's not only about the factor quantity or factor frequency of administration, the efficacy. When the patients were changed from the standard of life to extended of life concentrate, there was almost 60% reduction in the total bleeding rates. So with this EHL factors, even in the era of non-factor therapy, they still have a role, especially in surgical setting. We don't have anything except for the EHL factor, except for still the clotting factors hold a role in surgical settings and also breakthrough bleeding. Even on patients who are on emicizumab, if they bleed, if they have a breakthrough bleeding, still the clotting factor concentrates have a role. So with many pharmaceutical companies shifting towards EHL factors, reducing the manufacturing of SHLs, and also reduction in the gap between the SHL and EHL factor cost, there is getting closer. So it's probably the future seems to be more of EHL factors compared to SHL. So this is already discussed. Basically, the newer therapy, the concept, basically we have a natural coagulants like factor 8, factor 9, all clotting factors, and we have natural anticoagulants like antithrombin 3, protein C, protein S. So a human body has a homeostasis where you have an equal balance of natural coagulants and natural anticoagulants, so body is in a liquid state. So if there is, in cases like hemophilia where there is a reduction in the clotting factor concentrate, the balance is altered. So all these days we were rebalancing by infusing the clotting factors. So the newer therapies are directed towards whether we can reduce the quantity of natural anticoagulants like antithrombin 3 and tissue factor pathway inhibitors. So this is the concept behind the newer newer non-factor therapies. Thank you. Thank you.
Thank you, Dr. Vikram. With this, we've come to the end of our session for today. We thank you all for being with us on this evening on day 1 of Chakravyuh 2.0. Today, we traversed through innovations in hemophilia, glimpsed into the future, and heard firsthand about strategies in reshaping care delivery in hemophilia. As we break for the night, we invite you to return tomorrow for a full day of scientific sessions, patient-centered dialogues, and discussions on hemophilia care. So see you tomorrow at Amriteshwari Hall, Amrita Hospital at 8 a.m. sharp. Until then, have a restful evening and enjoy your dinner.